content in the blood. However, how do we check this oxygen content in the blood or simply the partial pressure of oxygen? That should be done through blood gas. As you know, the blood gas is a different thing. We cannot do blood gases repeatedly. But with this oxygen dissociation curve, you can observe that when the blood oxygen level is in some stage, the oxygen saturation, that means the amount of oxygen or percentage of oxygen which bound to hemoglobin will change. So because of that, the saturation we can use as a surrogate marker of blood oxygen level. So other important thing is you can see the 60. So this is usually our cutoff of partial pressure of oxygen in the blood. At the 60 level, oxygen saturation is around 90. And above 60, if whatever the things which go up, partial pressure of oxygen, saturation goes from the 90 to 100%. But the important thing is because of the sigmoid shape of this oxygen dissociation curve, if the oxygen tension reduce, that means the saturation dramatically reduce. So in the other way, if oxygen tension become less than 90%, that means the partial pressure oxygen might have drastically reduced. Say 90 to 88, 2% reduction of saturation might be an indicator of reduction of partial pressure of oxygen by 20. It's not 2. That's the thing. So that is the most important thing about this shape of the curve and clinical entity. That's why we are worrying. That's why we are making this some sort of cutoff limits, 94, 93, 92, 90 like things, because below that indicate patient is having significant hypoxemia. Okay. Right. Then how do we use this? So what is the exact principle of monitoring this using this pulse oximeter? I'm sure all of you have used this pulse oximeter. Has any one of you used a pulse oximeter with a different colored light? So we are using red color light pulse oximeter. Any other color? Blue color, green color? No. Because all the pulse oximeters, the light is red. So that is important because the principle they are using. Actually, they use two lights. One thing is red light, other thing is infrared light. All of our the saturation probes emit two lights, infrared light as well as red light. What are these two lights? So red light 660 nanometer wavelength, infrared light 940 nanometer wavelength. There are LEDs which produce this light, and the absorption of these light, when the light going through the finger or earlobe, some of these light get absorbed through the tissues as well as the hemoglobin content in the blood. And there's a detector. This detector detects the absorption or the level of absorption of this light. And oxygenated hemoglobin is red in color. That means how can we see colors? We can see colors, it reflects colors. Example, if an apple is red, that means apple reflect red color. If the sky is blue, that means sky reflect blue color. So the hemoglobin, oxygenated hemoglobin is bright red in color. That means it reflect red. It doesn't absorb red color, but it absorbs infrared color. So infrared light is to keep or monitor the oxygenated blood in the blood, and the red light look after the deoxygenated blood. As you know, deoxygenated blood is not red color, it's brown light color. So red light look after the red light monitor the absorption or the content of the deoxygenated blood. Infrared light monitor the absorption or the content of the hemoglobin, oxygenated hemoglobin. So then these are the wavelength. And so if the hemoglobin, bound hemoglobin concentration is low, low absorption, low saturation, high concentration, high absorb. Sorry, if there's high absorption, that means more oxygenated hemoglobin. So the machine then do some sort of calculation and it exerts as a ratio or the percentage. So this is actual graph which some sort of calculations happen within that small gadget. And finally, we can have the percentage saturation. So that's a simple the mechanisms which we are using this pulse oximeter. So finally, the ratio is the important thing, right? Okay, so the last part of this thing, next 5 minutes, I'll finish this. So it's a vicious cycle. So this is the most important thing we have to focus. This infection obviously leading to hypoxia. As I mentioned, there are many mechanisms which happen in COVID-19. And this hypoxia or hypoxemia leading to, again, inflammation, because hypoxic tissues produce more and more cytokine, and this more and more cytokines give more damage, and more damage, more cytokines, and then more hypoxia. So this will go as a vicious cycle. So this inflammatory response or significant tissue damage, tissue hypoxia produce more inflammation, more damage will produce more hypoxia. So we have to break this cycle in the management of patients with hypoxia, not only in COVID-19, but here our focus is on COVID-19. So it's very important, undetected hypoxia or hypoxemia, it is directly proportionate to the tissue damage or severity of the illness, and it exists as some sort of independent marker of morbidity and mortality of these patients. The other thing is it can be an important predictor that patients at risk of requiring admissions to the ICU. So the correct recognition of hypoxia or hypoxemia in the early part, as well as use of oxygen as early as possible, is the most important thing. Right. So then, very simple management is in COVID-19, we have to monitor them closely. So it's mainly upper respiratory tract infection in most of these patients, including children, but few of them develop ARDS or pneumonia or the rest of the complications. So we have to monitor them closely to catch this important group which can develop or who can develop this severe disease. And one of the important is respiratory rate, and we have to monitor the signs of hyperventilation, monitor oxygen saturation. We are using the saturation probe with that principle. And then sometimes we have to use some sort of invasive measurement of hypoxia or hypercarbia at regular intervals, like blood gases, especially in intensive care settings or high dependency settings. And most important thing is use oxygen appropriately. And not only the medical community, now the layman, the general public also know the importance of oxygen. That's why sometimes some people they have their own, or they tend to buy oxygen cylinders, which is obviously not a wise thing. If the patient needs require oxygen, obviously they have to admit to a hospital. But even that, some patients even oxygen concentrators collected and keeping in home. So because this is very important to break this cycle at the beginning. So if you use oxygen appropriately, so this COVID-19 infection, viral replications, pulmonary infiltrations, and in hypoxia and hypoxic pulmonary vasoconstrictions and cytokine release. So this is the normal path, the pathway which is happening, which I already mentioned at the beginning of this presentation. While giving oxygen, you can minus all these steps. That means you can at least reduce the rate of deterioration, and most of the time you'll be able to finish or arrest this progression of this significant infection, inflammation, hypoxia, and hypoxia inflammation, the cycle. Okay, so this is, I'm sure you know about this thing. Just to recap one slide, the prone position is one of the important thing, just to give the principle to maintain oxygenation, especially in early hypoxic patients. In supine position, you can see these are the lungs. lung bases are the most important part which involve in the ventilation or the oxygenation of the body, because lung bases get the maximum perfusion. But the problem is because of this weight of the heart in supine position, lung get compressed. Because of that, the ability to expand alveoli will be little reduced, as well as the in supine position, abdominal organs also exert some pressure on the lung bases. So because of that, so this is not a problem in a normal person, because we use only about less than 25% of our lung capacity of the lung reserves in the normal state. But if the lung is only damaged, lung is diseased, this type of small things also would be very, very important. In prone position, you can see this is prone, so this is the backside. There's no weight of the heart on the lungs, and especially the lung bases can expand adequately, as well as this abdominal organ might not produce that much of pressure on the lung bases like in supine position. So this is an important thing. So in supine position, we can see more alveolar collapse, but in prone position, it relieve these collapse and will less. It's increase the ventilations and perfusion already there to the lung bases. So that means it's increased the ventilation perfusion, or at least it's reduced the ventilation perfusion mismatch. So this is the principle of using prone positioning. So in summary, hypoxia is one of the major factors which lead into the morbidity and mortality of COVID-19. And there are different pathophysiological processes in addition to usual ARDs which happen in COVID-19. As I mentioned, so almost all the mechanisms of hypoxemia can happen in patients with COVID-19, especially the severe pneumonia, severe ARDS disease. In addition to that, it can have microthrombi formations which added to this burden, and because of that's all leading to significant hypoxia. In addition to this issue, apart from this overt hypoxemia, sometimes they might have silent hypoxia. That means at the time of presentation to the hospital, they might have significant problem, as evident by our child, 12-year-old child, that one get arrested on admission at LRH, unrecovered. And so because of that early identification of these key things, as well as appropriate and early use of oxygen and adequate respiratory support is the key management option, because still we don't have a proper specific management options for COVID-19. Thank you very much.
Thank you very much, sir, for that detailed lecture on COVID-19. So anyone's having questions can ask until the next lecture starts. Seems to have no questions. So thank you once again, Dr. Chandu De Silva, consultant pulmonologist at LRH. So
thank you very much, Dr. Shan and the team. Thank you.
Thank you, sir. So next up is Dr. Deshan Adiheti is doing the lecture. Are you doing, Dr. Prashant? Yes.
Okay, so I could not mute. I'll be doing the lecture, Dr. Roshan.
Okay. Yes. So Dr. Prashant Dalpadaru, consultant neurologist at on alter level of consciousness. Right. Over to you.
Okay, so let me start by saying that it's been a long while since I've been RHO and going on to do my postgraduates. But what I remember when I started my career in pediatrics, one thing I dreaded was this, patients coming to you with these acute problems. Now you learned about hypoxia, COVID and all that. And a cyanose child is such a dramatic thing. Similarly, imagine a mother carrying a child running towards you saying, "Baba, doctor, mage baba geheno." And imagine the atmosphere that would subsequently arise in the ward. The nurses running here and there, minor staff trying to get the oxygen, and all the mothers in the ward will gather around you. And sometimes you are the only doctor available, and everybody is looking at you to try to get this baby's conversion resolved. So you are like at a really you are at the spotlight of your life, and you have to somehow get over this. So my next 30 minutes attempt is to give you some knowledge and maybe some basic competencies in trying to manage a child with a neurological problem. As I was introduced, I am a pediatric neurologist at Kurunegala. Sorry, I'm going to off my mic, my camera for the rest of the lecture because my connection is unstable. But we will try to discuss points on a child with altered level of consciousness, and second, a child who's convulsing. Now, in any situation, in any case where you get a child who is having a problem, whether it's neurology, cardiology, respiratory, you start with your structured approach. Your structured approach is your A, B, C, and D. If you see a child convulsing, if you see a child unconscious, you do not go and manage the neurology straight away. So things that can kill the child first are the respiratory collapse, respiratory failure. The second one would be your cardiovascular failure, or what you call a circulatory failure. And then only comes the neurological problems, or what you call the central nervous system failure. So make sure when you see a child not to panic, go in a methodical fashion, assess the airway breathing, see whether there is any obstruction, relieve that obstruction, put some high flow oxygen, assess the cardiovascular system. If the child is hypotensive, resuscitate the cardiology with bolus of fluids, and then only you go on to manage the D, or what you call the disability, and the neurological issues. Now, neurological issues, when you say neurology, people are scared. People think it's very difficult. Neurology is a systematic method. You only need to know what the pathology is and where the pathology is. And in the acute situation, there are only three things for you to assess. First one is assess and rate the conscious level. How conscious is this child? Second one would be to look at the eyes. You are looking at the eyes to assess the pupils. And the third one is looking at the arms and legs, and you are looking at the arms and legs to see whether the child is in an abnormal posture. So those are the only three things that you need to quickly decide what is abnormal with this child's brain. Alright, so we will try to quickly do a few cases. I will not be asking you questions. I will just demonstrating how you do this. Now here is a 7-year-old child who had come to you unconscious with an altered level of consciousness. He is responding to verbal stimuli. His motor responses are withdrawing to pain, and he is conversive but disoriented. When you get a child like this, once you stabilize the ABC, you go on to your D, disability. Now, assessment and rating of consciousness you can do in two ways. One is the very quick rapid method called the AVPU, that is whether the child is alert, responding to voice, responding to pain, or completely flat and unresponsive. So when you do that, the two things that matter really are whether the child is responding to voice or whether the child is responding to pain. If the child is responding to pain, that will tell you that this child's airway is not patent or not secure. So you need to make sure that you secure the child's airway, either putting a oral airway, or you might need to intubate and ventilate this child. That will also tell you if the child is having an altered level of consciousness, something is wrong somewhere in the central nervous system. It may be other system affecting the brain, or it may be the brain itself that is now diseased. Now when you AVPU is this rapid method, and it is a very broad scale. But when you need a more expanded, more detailed assessment of the conscious level, we go on to this Glasgow Coma Scale. In children, we called it a modified Glasgow Coma Scale, and I'm sure you have heard of it. I always tell this when I do this lecture, you don't need to remember the 15 individual components. They are grouped into 3: eye-opening, motor response, and verbal response. Have these at the bedside of your admission bay when you go at your place of work. It can be the ward, it can be the admission bay at the OPD, it can be the ICU, or it can be even the theater recovery room. So have it there when you need to assess the conscious level. You can elicit the individual responses and score. Now this says eyes responding to verbal stimuli, and that means for the eye component he is getting a score of 3. And he is withdrawing to pain, so that is a score of 4. And he is disoriented but conversive, so that means he is confused, and that is a score of again 4 for the verbal response. Now if you add together, it will be 11. Now it's important that when somebody asks you what is the GCS of this child, not to say the GCS is 11 out of 15. Because there are 3 individual groups that are there. So each what the score is in each individual group does matter to a senior colleague when you present the patient. So make sure when you say that you break it down. So you say E3, M4, V4, and the total score is 15. That would give a lot more information than just saying GCS is 11 out of 15. Now the same patient a few hours later now has deteriorated. So now he is you can see his eye response is to pain only, motor response remains withdrawing to pain, and the verbal response is now incomprehensible sounds. So in the AVPU scale, he is responding to pain, and in the GCS, E is 2, M is 4, and V is 2. So that is a score of 8 out of 15. Now, so GCS is very good at picking up subtle changes in conscious level, whereas AVPU is a rapid scale, as I told you earlier, which is more of a very something that you can do for a quick assessment. Here you can see that when the child was responding to voice, the GCS is 11. When the child was responding to pain, the GCS has dropped to 8. So there is a correlation in the AVPU to GCS. And what you should do now is you should make sure that the airway is secure with the airway or intubation procedure, and the child requires a good flow of oxygen. So that is for assessing and rating the conscious level, the first component of assessing disability. Now the second component of assessing disability is looking at the eyes. There is an English saying which says that the eyes are the window to your soul. I always tell that so that you will remember. I have modified this to the neurological setting to change it to say that the pupils are the window to your brain. By just at looking at the pupils, you can decide what is wrong with this child. I can give you 10, 12 conditions, and all these conditions can be grouped into these 3 groups. So if you have a pinpoint pupil, you are very likely to have a child with a certain condition. If you have a unilaterally dilated pupil, you know this is a surgical problem in the third nerve, or something is happening on that side, on a given side. And bilaterally dilated pupils will be another set of conditions. So just by looking at these pupils, and if you know a little bit of history, you can quickly come to a diagnosis and decide on your pathway that you will follow to recover this child. All right. So this is what I was telling you about. If you have pinpoint pupils, pinpoint pupils, it can only be 2 things. The child has had a ingestion of some opiates, or there is some sudden catastrophic thing that is happening in the midbrain pons and the medulla, like a hemorrhage, or a expanding tumor. So something is happening in the midbrain, or the child has taken opiates. Either of the two, a quick history will tell if the child has been completely normal the day before, next day morning wakes up unconscious, altered conscious level with pinpoint pupils. Okay, this child is probably had ingested some opiates overnight, and that is what you need to do to act and recover the child. Otherwise, if the child has been unwell for a period of time and then is not been the usual self, he probably might need some imaging. Now, as I said, let's go to the last picture, which shows a dilated pupil on the right. And dilated pupils are usually due to a surgical third nerve that is compressing the third nerve. It can be like something like somebody has put atrophy into the eye on that side. So that is why it says toxic metabolic. Or it can be a midbrain lesion on that side. If you have bilaterally dilated pupils, that can be a global something that is happening inside the brain. So the whole brain is now affected due to something. It can be drowning, it can be ischemia, it can be anticholinergic drugs that you have taken orally, or it can even be a seizure or a post-ictal event. So those are the the 3 categories, 3 things that you need to remember. Know a little bit of history, you can put 2 and 2 together and decide what is wrong. The next one, the third component of a neurological assessment or the disability assessment, is looking at the arms and the legs. There are lots of things you can look for. You can look for the symmetry, tone, deep tendon reflexes, all that. But I would just say have a quick look. See what the posture the arms and the legs are held in. If the arms are flexed and the lower limbs are extended, that is called a decorticate posture. If both limbs are extended, as in the second picture, picture B, that is called a decerebrate posture. You can remember this by imagining a rugby player hugging the ball and running. So, or what you call the cord the ball posture. And that is a decorticate posture. Now, both of these postures tell you that there has been something going on for some time, and the brain has got increased intracranial pressure, and that is why the child is having an altered level of consciousness. So it says that there's raised intracranial pressure, something globally is happening inside the brain, and the child might be having impending coning. So you need to act quickly when you see these two postures. Decerebrate is the worst of the two. All right. So now that is how you assess. You have to know a little bit about what are the causes of altered level of consciousness. These are things you probably know. It can be a metabolic thing. Usually hypoglycemia is the most notorious thing. You need to check your RBS. Always remember to check the RBS. It can be electrolyte imbalance, a global hypoxia. It can be something catastrophic happening inside the brain, like an intracranial bleed. It can be arterogenic, like poisoning or something like that. It can be a convulsion or post-convulsion, post-ictal drowsiness. And it can be something completely outside the brain or the central nervous system, something like such as arrhythmia or something such as hypoxia that you learned all about in the previous presentation. Okay, I'm just putting up what you'll have to look at. You need to look at the abdomen to see whether there's bruising, rigidity, which will tell a distension, which will tell there's some abdominal pathology or sepsis. You have to look at the whole body, the skin, which gives you a lot of information about trauma, bruising, the state of the perfusion, etc. Scalp, again, look for trauma, hemorrhages, rashes, CSF leaks and bleeding in the nose, pupils and breath you have to look at, and the breathing patterns. So just a general secondary examination you would do, quickly looking for evidence for the diseases that you have suspected with your disability assessment and your knowledge about a drowsy child. All right. When you have a child who is having a reduced conscious level, one of the most important things that you need to realize is whether I need to assess and see whether this child has what is called a raised intracranial pressure. Now, acutely raised intracranial pressure can be due to cerebral edema. It can be due to something like a hemorrhage. You can remember that the skull is a rigid box. Inside you get the brain and the blood vessels. Anything extra like a tumor will cause increased pressure. If the brain swells, the brain tissues get swollen, there's increased pressure. Any vascular event will cause increased pressure. Now, how can you identify whether there's a raised intracranial pressure? There's something called a Cushing's triad. A Cushing's triad is hypertension, bradycardia, and the abnormal breathing patterns. This is physiology that you learned in your first and second year medical school. But these are pre-terminal signs. If these are there, the child, you have to act. You haven't got time. The clock is ticking. The child is quickly deteriorating, and you might lose the child. What are the things that can give you information earlier than that? One thing is again the pupils. If the pupils are getting dilated and they are sluggishly reacting, that is a sign of raised intracranial pressure. The reduced GCS itself is telling you that there is raised intracranial pressure, there is some form of edema or some form of inflammation inside the brain. Now, you can see that I have crossed off papilledema. Papilledema is a sign of chronically raised intracranial pressure, and it is not a sign of acute ICP, raised ICP. So remember, there is no point poking, with a ophthalmoscope trying to see papilledema, which you might not even see in a normal child sometimes, if you are not used to or experienced enough to see, visualize the fundus. So papilledema, forget about it. Look at the pupils to see whether how reactive they are. And if you are seeing any form of Cushing's triad, act quickly. You need to because this brain is now going down through the foramen magnum, and you are going to lose the child otherwise if you don't do anything. So management of raised ICP, there are two broad principles. The first principle is trying to keep the child quiet as possible with the reduced metabolic rate, without the blood vessels getting kinked, with the head getting kinked. So you keep the child elevated 20 degrees, head in the midline, with treat the convulsions, keep the body temperature to a minimum. Those are the general principles of managing raised ICP. Specific, if you are suspecting raised ICP as a cause for the reduced conscious level, you have to intubate the child. A little bit of hyperventilation, trying to get down the carbon dioxide, would be good, but we do not want the carbon dioxide going below the low limit. So low normal carbon dioxide will cause a little bit of vasoconstriction, reduce blood flow to the brain, and will reduce the intracranial pressure. Blood pressure is a very important thing. Cerebral perfusion pressure equals mean arterial pressure minus raised ICP. That is what I learned when I was a medical student. Now, if you want to maintain the cerebral perfusion pressure, you have to maintain the mean arterial pressure. That is, you have to maintain the blood pressure. So if you are feeling that the capillary fill time is prolonged, pulse volume is not to what you expect, blood pressure is going down, give a fluid bolus, you might need inotropes. And what can we do to reduce the intracranial pressure? So we can give mannitol, we can give 3%. If you know the sodium level, if it's skyrocketing, you cannot give 3% sodium. Then you need to give mannitol. Otherwise, you can give mannitol. You can see the management of raised intracranial pressure is directed towards maintaining blood flow and perfusion in the brain. So that's why you have this cerebral perfusion pressure equals mean arterial pressure minus ICP. So your main target is maintaining the cerebral perfusion pressure here. So that is your direction in management. Now remember, your medical management can go so far. Will go so far. If your medical management fails, then what you need to do is you have to quickly call the neurosurgeon in, or transfer this child to a place where the neurosurgeon is. So the neurosurgeon will break this rigid skull box, so that now the brain can expand outwards, not go down the foramen magnum, and that will dissipate the cerebral perfusion pressure. Okay, so these are some of the management for specific ones I am not going to discuss. So I need to quickly tell you what to do for a child who has a prolonged convulsion. Now, if the child has a prolonged convulsion, the definition of the status is slightly different now. We have put timelines. If it's a generalized convulsion, 5 minutes is the cutoff, which will say that's a early or impending status epilepticus. 30 minutes is where now the status epilepticus has established, and the child and your chances of converting this to a normal rhythm is going to be low. So you need to act fast at 5 minutes. 5 minutes. So always airway breathing circulation. Always remember to check the blood glucose level. And during that first 5 minutes, what is important is you try to identify causes that you can reverse. Sometimes you act, your adrenaline is pumping. Everybody is shouting at you, get this convulsion settled. So you forget about these things, and you straight away put in a cannula and push the phenobarbital in. That is what I have seen in the wards. or you push the diazepam in, and you are so keen to push this in, you have given a very fast bolus, a child goes into a respiratory failure. So that is what happens. Now, don't forget to think about the reversible causes. Blood glucose I told you about. Another thing is blood pressure. So think about blood pressure, and the common thing is obviously infection. So give a bolus of not a bolus, you give a broad spectrum antibiotic as well if you do not have a history of a past seizure or past history of epilepsy or whatever. You can give a broad spectrum antibiotic as well. So other things, hyponatremia and electrolytes, you might need to think about rest ICP. You might need to think about a bleed inside the head. Now, the first thing is to give a benzodiazepine. During that first 5 minutes, if possible, get an IV cannula in. Now, they have done lots of studies. IV route is better than your rectal route or your buccal route. You are more likely to convert the convulsion and normalize the child if you give IV rather than giving other routes. If you have, then the other question is, am I to give midazolam and am I to give diazepam? So if you have midazolam, I would say give midazolam because midazolam has a quicker onset of action, longer onset of action, and less respiratory side effects. So IV midazolam, if you are competent, you can put an intraosseous line in. But I know there are practical problems to this. Sometimes the child is convulsing, you cannot get an IV line. Midazolam is not found in the very peripheral or rural hospitals, so you only have diazepam. Then you have to give diazepam. Doses of these emergency drugs you have to remember. The second drug is again, after the first 5 minutes is a diazepam or a midazolam, and then the third step would be to give phenytoin or levetiracetam. This is the new algorithm for the APLS teaching. Both drugs might not be available in your peripheral rural setting. In that case, you might have to give phenobarbital. Phenobarbital is 20 per kg, phenytoin is 20 per kg, levetiracetam is 40 per kg for those of you who will go on to work in teaching or base hospitals or pediatric wards. And if all fails, if you are running out of time and the convulsion is still going on, you have no option but to intubate and ventilate the child and start maybe a midazolam infusion, hoping to increase the dose in quick aliquots until you get what you call a burst suppression inside the head. So that is very quickly the algorithm to manage a prolonged convulsion. And some of the causes, if you have a very quick history and a rash, it's probably meningococcal sepsis. It's a very rapid onset in a normal child. It can be poisoning or a hemorrhage. If mother tells you a story and the father contradicts, and the grandmother tells you another completely different story, that is a non-accidental injury. Blood pressure is always important, especially if you have edema, hematuria, tea-colored urine, that sort of thing. All right, any questions? You can put in the chat box. Any questions? I will ask, so somebody wants the lecture, so I will ask Chanaka to give you, send you a soft copy if that is permitted. Or you can even get the recording of the lecture. Buccal route is actually used. Yes, you can use the buccal route if you have, so you can't put an IV line in if you, or intraosseous line in. What we advise is that you use midazolam in the buccal route. In other countries, they have this preformed what called buccalam. It comes in 2.55, 7.5, 10 milligrams. But here you can and you can give those doses according to the age. You are not injecting to the buccal midazolam. You are just you are between the teeth and the buccal mucosa. You are spraying the midazolam, and you can massage that place so that it gets absorbed, which to use to reduce ICP, mannitol or 3%. So that's what I said. Now, if you have, you can't use 3% if the sodiums are high. Like if your sodiums are 150, I don't advise to use 3% sodium chloride. But if it's at the start of the illness and you are thinking about raised ICP, you can probably give a 3% sodium chloride bolus, and then you can monitor the sodium. Otherwise, if it's high, you have to give mannitol. The problem with mannitol is it not only sucks out the fluid from the brain when it goes to the intravascular space, because of its osmotic capabilities, it will take that fluid out through the kidneys and your urine. So what will happen is you are going to lose your blood pressure. I said cerebral perfusion pressure equals mean arterial pressure minus ICP. So if your mean arterial pressure drops, then that is a problem. So that is where you need to balance. 3% is not available in rural hospitals. You might only get mannitol. In inward child, if we encounter a fitting child, do we straight away go for pharmacological management, or we can wait for 1 to 2 minutes? So remember my entry to this lecture, a mother running with a child telling this child is fitting. So you don't, that's what I said. I have been, guilty when I was a house officer of, putting in the cannula and giving a phenobarbital at the first instance, which in hindsight, I'm not sure why I did that, because of the anxiety of the whole situation. What you do is you put the child in your examination bed in the recovery position, manage the airway breathing, suck out the secretions, put face mask oxygen, check the circulation. If the circulation is low, give a bolus, and check for the reversible causes that I talked about. So you have 5 minutes. You have 5 minutes to do that. Only at 5 minutes you start giving your first dose of benzodiazepines. So I hope that is clear. Don't go in and rush to give phenobarbital at the first instance. What else? You can, because most of these seizures will settle within 1 to 2 minutes. So you can wait for 5 minutes before you act. If we encounter fitting child, most of the seizures we settle in few minutes. So that is what I am telling. So you need to wait for 5 minutes before you give your drugs. Dear sir, can you please explain how mannitol reduces MAP? So mannitol is an osmotic diuretic. It goes through the kidneys and then to the urine, and it carries the fluid with it. So in the brain, it's the same thing. Because of its osmotic properties, it will attract all the fluid towards it, and it goes through the urine. So you not only do you lose your cerebral edema fluid, you use your intravascular fluid as well. So that is what I meant by when the intravascular volume reduces, the mean arterial pressure will reduce. Any other questions? How do you assess GCS in a neonate or an infant? So GCS, in children is called a modified Glasgow Coma Scale, and in less than 1 year old, it is further modified. Let me see whether I have put that here to incorporate these things. So it's I have not put it there. So there is certain modifications that have been done to assess GCS for a infant. So you will, it's mainly in not the eye-opening, motor responses and verbal responses. So you might have cooing. Normally you are responding to mother's stimuli. Those things have been changed there in the infant. So you can use the Glasgow Coma Scale. Do we need to repeat the midazolam or diazepam before? Yeah, so you need to repeat. So I have rushed to the convulsion lecture. So first thing is you give a first dose of benzodiazepine, midazolam or diazepam, wait for 5 minutes, and you give a second dose of midazolam benzodiazepam, wait for another 5 minutes, and then decide whether you give phenytoin or phenobarbital. So you when you decide to give phenytoin phenobarbital, altogether from the first 5 minutes to second 5 minutes to third 5 minutes, 15 minutes have gone. So what is the dose for mannitol in children? You have to look at the BNF, because I don't, that is I think 7.5 ml per kg, so I'm not sure. 3% of course is 3 to 5 ml per kg. Please check in the BNF for the dose for mannitol in children. Any other questions? Or shall I stop, because I have to go to my clinic now? Thank you all for the interaction and all the questions and the comments made about the lecture. Shall I hand over to Roshan for
Yes.
continuation of the program?
Yes, thank you, Dr. Prashant Dalpadadu, consultant pediatric neurologist, for the detail his lecture and the interaction with the participants and giving answers. So next up is oxygen elimination, carbon dioxide elimination, oxygenization by consultant intensivist, pediatric intensivist at LRH, Dr. Manjula Hevagian. So are you there?
Recording stopped.
Dr. Manjula will join shortly. I think he was at the board rounds. So give us a minute. Yes, Sharon, what's the problem? So we noticed some vivid naming of your login names. I guess that reflects your uh, preferences, I guess. So enter the dragon one name. So I notice. So you all can take a few small break. I think Dr. Manjula is facing some connection issue. So he will join shortly. Until then, take a small break.
இல்ல இதுக்கு இந்த லெக்சருக்கு నాకు இன்னைக்கு அருகது மில்லியனத்து 900.
So your mic is not visible. So are you there? I think your tea break is over. Dr. Manjula Hevagigana had some issue with the computer, so that lecture will be followed by Dr. Nalin Kitulwasa, consultant pediatrician's lecture. So now we will have monitoring in COVID positive patients by Dr. Nalin Kitulwata, consultant pediatric intensivist at LRH. So we'll start the lecture shortly. So those who have taken the break, so I think break is over now. So ask everyone to join now. Good morning, sir. We can't see your mic, sir, actually. Nalin, sir. So we can't hear you, actually. So when you're sharing the slide, there is this tick box on the bottom of sharing with sounds. And your mic is not showing on the against your name, I think. Sir, good morning, sir. Might have to unmute, sir. So again muted.
Now?
Yes. We can hear
Right.
you, yes. Right. You can start from the beginning, sir.
Yeah. Okay, sorry about that. So now this lecture is about the patient monitoring.
Recording in
especially,
progress.
Related to the COVID-19 pandemic and escalation and de-escalation of oxygen therapy and recognition of the multi-system inflammatory syndrome in children. So this is my outline. So basically the same thing. Again, I'm going to discuss very brief, touching all these things topics, starting from patient monitoring. oxygen delivery devices, escalation and de-escalation of oxygen therapy, and a little bit about multi-system inflammatory syndrome in children. So these are the clinical observations. This is related to COVID-19. If you forget about the COVID-19, critically ill, all the children needs these parameters to be monitored. So heart rate, respiratory rate, saturation, temperature, level of consciousness. So this is a very basic AVPU method. Or if you are conversant, if you are happy, you can use the Glasgow Coma scale. And blood pressure, capillary return time or capillary refilling time, and what is the oxygen therapy that you are giving. What is important is that at any point of time, just monitoring these things will not show anything. It's not that important. What is important is what is happening to these parameters over time. In other words, trend. What is happening to the heart rate, whether it's going up or down or static. Respiratory rate, saturation, temperature, level of consciousness, whether it's going down. So likewise, so what is important is the trend. So this is a chart developed by the other countries with a lot of studies. We call it Pediatric Early Warning System score, PEV score. So here you can see that we have temperature, we have heart rate, blood pressure, respiratory rate, then oxygen saturation, consciousness level, like AVPU, pain, likewise, a lot of things are there. So important thing is there are some color codes. You can see that red areas are there, green areas are there, and yellow areas are there. So depending on the parameter, whether this parameter is deteriorating or improving, you can measure, you can get an idea over the time if you can measure the, if you can monitor these parameters over time. So that's the important thing. So what is important is the trend. So not only that, so you can see that this is what happens. So over time, what you can see that the respiratory rate, what has happened to the respiratory rate over time, whether it's a static one or whether it's going up. So that is the important thing. And then there should be a scoring system. You can see that if the respiratory rate is in the red area, you are giving a number. If the respiratory rate is in the yellow area, you are giving a number. Depending on that, there's a scoring system. So score is 0 to 2 if you are in the green area, 3 to 4 in the yellow area, 5 in the this thing. And this is the response actually. So now if you have one number, what you should do, that is also important. Sometimes we can see that very closely we are monitoring, heart rate is gradually coming down, respiratory rate is going up, and saturation is going down, and at the end child dies. So nobody has bothered. So we have monitored nicely, but nobody has bothered. That is useless. So we should have a response depending on the score, what to do. Now you can see that if the PEV score is more than 6, so this is what you should do. Repeat in 20 minutes, vitals every hour, immediate pediatrician response, and possible transfer to PIC. So if the PEV score is more than 6, that means child is in danger. So these things should be done. So that is what we call about the monitoring. So in any type of ill children, we are monitoring these parameters. It's very important to monitor over time. In other words, you have to get the trend, and depending on the trend, there should be a response. So then only you can prevent unnecessary deaths, unnecessary ICU admissions, unnecessary deterioration of the children. So that's about the patient monitoring. Then about oxygen delivery devices. So these are the commonly used oxygen delivery devices that we have. We have nasal prawns, we have face mask, we have venturi mask, we have non-rebreather mask, and at the end, high flow nasal prawns. So I think you may have seen these things. during your work as an intern. So important thing is that all these devices, there is a minimum flow and there is a maximum flow. Depending on that, how much FiO2 that you can deliver through these devices. This is very important. For example, you take nasal prawns in a neonate, minimum flow should be 1 liter per minute. We have seen that various times when the child, especially they are improving, you are giving only 0.5 liter per minute. So that is useless. So if you are using nasal prawns, it should be, the minimum flow should be at least 1 liter per minute. And maximum is, depending on the age, again, neonate is 1. So that means if the neonate is on nasal prawns, it should be 1 liter per minute. Nothing less, nothing more. No point delivering more, no point delivering less. And if the child is more than 4 years, minimum is 1 liter per minute, maximum is 5 liters per minute. So depending on the clinical parameters, depending on the saturation, we should increase the amount of flow that we are giving. By using this type of thing, you can achieve FiO2 from 28 to 40%. So that is about nasal prawns. Face mask oxygen, it should be minimum 5, maximum 10, 44 to 60. Venturi mask, we'll discuss what you mean by Venturi mask. Depending on the color of the Venturi valves, again, you can get 24 to 60. Non-rebreather mask, minimum 10, maximum 15, is 60 to 95. High flow nasal prawns, it should be 2 liters per kg per minute. So this is the only place that we're using per kg dose. Here, it's not depend on the weight. So in a high flow nasal prawns, it is depend on the weight of the child. Maximum is 60 liters. You can deliver 21 to 100%. So important thing is, so there's minimum flow, there's maximum flow, and this is the FiO2 that we can achieve. You can see nasal prawns up to 40%, face mask oxygen up to 60%, Venturi mask again up to 60%, non-rebreather mask up to 95%, high flow nasal prawns you can go up to 100%. So that is very, very important. So these are the some of the devices. You can say that the nasal prawns, here and the other nasal prawns. This is a non-rebreather mask. And this is Venturi mask. I'm going to discuss it further in the minute time. So high flow nasal prawns at the end, intubation. Right. So a little bit about non-rebreather mask. There's an oxygen reservoir. You can see this is my oxygen reservoir. And there's one-way valve system. That means this reservoir can send oxygen only this way. When the patient is exhaling, that exhale gas cannot reach this reservoir bag. So there's a one-way valve system. So if you fill this up, that filled oxygen can go to the patient, but patient's exhale gas cannot reach this reservoir bag. So that's one. So prevent exhale gas mixing with fresh gas flow. There's a valve on the side ports of the mask which prevent entrapment of room air into the mask. So there are valves here. So again, when the patient is breathing in, the room air cannot go in. Room air cannot mix with the inspiratory gas. So only through this reservoir bag, patient can breathe. So again, room air entrainment is stopped. And here we can provide higher concentration of FiO2, 60 to 95%. The definite thing, it should be before starting, the reservoir bag needs to be inflated prior to the to placing on the patient's face. That's very important. Otherwise, a patient cannot breathe. Now you can understand. So this is one-way valve. So patient cannot breathe through this, only exhalation. And only way the patient can breathe is through this reservoir bag. So the reservoir bag should be filled before putting into the patient. So these are the Venturi mask. So it's a normal face mask, and there is a connection here and with the Venturi valve. There are several Venturi valves are there with color code. Depending on the color code, we can select the FiO2. So this uses Bernoulli principle. If you think about, if you see about this, the valve, you can see there is a nozzle here, and this part is connected to the patient's port, and we can connect your oxygen gas flow from this end, and there are some holes in between. So if there's a very high jet of gas going through this, because of this jet, there's some room air entrainment is there. So at the end, when it's going to the patient, it's oxygen plus this entrained gas. So entrained room air, when pure oxygen is delivered to the small orifice, resulting in a large total flow at predictable FiO2, delivers 24 to 60% of FiO2. Different colors delivers different rates of oxygen. So you can see that if there's a blue color Bernoulli, the blue color Venturi mass, then the flow should be 2 to 4 liters per minute, and then you can deliver 24% FiO2. You can see. So if it's a blue color one, you are giving 2 to 4 liters per minute, and you are getting 24% FiO2. So if you are using this, you have to select the flow, and depending on the flow, you can select the amount of oxygen that you are delivering. On the other hand, if it's a green color one, so if it is this one, so you can use 12 to 15 liters per minute, and you can achieve about 60% of FiO2. So that's how it works. Again, I have highlighted this. So there's a minimum flow. So nasal prawns is 1 liter. Face mask, 5 liters. Venturi mask, depending on the color of the venturi valve. So we have seen that. And non-rebreather mask, 10 liters a minute. High flow nasal prawns is 2 liters per kg per minute. So the importance of this, no point using these devices below the minimum flow. So that's commonly misused and commonly happening in Sri Lanka. We are using these devices with lower flow than this recommended minimum flow. So if you're using high flow nasal prawns, it should be 2 liters per kg per minute. If your child is 10 kilos, it should be 20 liters per minute, nothing less than 20 liters. So that is very important. Otherwise, you are just wasting your oxygen. Right. So then about the escalation of therapy. So when you are escalating, so important thing is start with the minimum one. So you are starting with nasal prawns. You can see that you can provide up to about 40% of the FiO2. Then if the child is not improving, you can go to the face mask. You can go up to about 60%. So failing that, Venturi mask also delivers the same amount with the face mask. Then you have to go for non-rebreather mask. You can deliver up to 95% of the FiO2. And then at the end, if everything fails, then you have to go for high flow nasal prawns. So that is all about the escalation. Start with nasal prawns. Target FiO2 is 92%. Target oxygen flow with your saturation. Please don't waste oxygen. And escalate therapy, that means changing the device depending on the saturation after 2 hours. You are starting with one device. You about 2 hours. If the saturation is not improving, you have to change your device. So we have already discussed nasal prawns, face mask, Venturi mask, non-rebreather mask, and high flow nasal prawns. Right. So then this is very important. New findings found when you are dealing with COVID patients. So if you are using a simple surgical mask on patient over nasal prawns, 2 things will happen. So this face mask, the simple surgical face mask, is on top of the nasal prawns or high flow nasal prawns or non-rebreather mask, whatever it is. So if you are using the oxygen delivery device, on top of that, you are putting a mask. So that will provide 2 things. One is this reduces the viral spread of staff and other patients. So that will not, the virus cannot go out easily. And then there will be a CPAP effect also because we are just putting a mask. So we think it's a very simple, but it's very, very effective. So this is what happens. You can see, so they have monitored these parameters with the various oxygen delivery devices. You can see that this is, you can say, no therapy with mask. So they are not giving any therapy, but with mask. No therapy without mask. You can see that how much air is going out if you are not wearing a mask. This is low flow nasal cannula with mask. Low flow nasal cannula without mask. So without mask, a huge amount of gas going out. That means air dispersion. That means even the virus can go out. So this is high flow nasal prawns with mask. This is high flow nasal prawns without mask. Right? See the velocity. So that clearly shows when you are using a simple surgical mask on top of your oxygen delivery device, that will definitely reduce the exhalation of the air dispersion with surgical mask. So that is very important, especially when you are dealing with COVID patients. So what we want is, we don't want to exhale viral particles so that the care provider can get the disease. So that should be very important. And not only that, this is a very simple study that they have shown surgical mask over high flow nasal prawns and oxygenation. You can see this is high flow nasal prawns. So this is high flow nasal prawns with surgical mask. So when you're on surgical mask, this black area, so it's always PaO2 is high. Saturation is high. PaCO2 removal is high. And PF ratio is good. Again, what is the important thing is respiratory parameters with high flow nasal prawns alone and high flow nasal prawns plus surgical mask. Improvement in all variables. That is what we say, that there is a PEEP effect if you put a simple surgical face mask over any oxygen delivery devices. So that's what we are practicing in our ICU at the moment. And then this is about the COVID patient. So they have compared the non-invasive ventilation with invasive ventilation. So the high flow nasal prawns is red, early intubation is blue. You can see this side, 61 patients, so 2 arms. So what happens is all the parameters are better if you can manage this patient on high flow nasal prawns. This is about the COVID patient. High flow nasal oxygen in patient with COVID-19 associated pure respiratory failure. So ventilator-free days are more. Intensive care unit length of stay is less. In-hospital mortality is less. So that shows that high flow nasal prawns is better than early intubation when you're managing COVID-19 patient. So that is very important. Early in the disease, all the guidelines says as soon as possible intubate this patient, because that will prevent the virus being spreading to the other patients and the other hospital staff. So we were doing this and the mortality was very high. So now we see that with high flow nasal prawns with non-invasive type of ventilation, the outcome is much, much better. So these are the ventilation guidelines published by the European Society of Intensive Care Medicine and the Society of Critical Care Medicine in 2020. With this is related to COVID-19 patient. So start oxygen if saturation is below 90. Target saturation is 94 to 96. Start with conventional therapy. If fails, high flow nasal prawns.
Recording stopped.
And high flow nasal prawns is better than non-invasive ventilation. If high flow nasal prawns is not available, you can go for non-invasive ventilation, and very, very close monitoring is very important. And early intubation is in a control setting if worse. So that is important. You're starting with the small,
Recording in progress.
You're starting with the least invasive oxygen delivery device like nasal prawns, gradually increasing. And those are the considered as conventional therapy. If fails, go for high flow nasal prawns. And if you think that the child is dyspneic and high flow nasal prawns are not going to work, early intubation in the control settings is worse. So this is what I told. So start with nasal prawns, escalate depending on the condition. If distress, go for hypernasal prawns. Your target saturation is 94 to 96. And if the child is improving, de-escalate depending on the condition. Close monitoring is important. And if the child is deteriorating with this non-invasive method, early control intubation is a must. So what about de-escalation? And again, I'm highlighting, don't use less than minimum oxygen flow in each device. So when you are de-escalating, this is very common. So no point giving 0.5 liter per minute through nasal prawns. So it should be at least 1 liter per minute. So when you are giving 0.5 liter per minute, that means you are just wasting your oxygen without anything. So de-escalation, we see that the child is on hypernasal pause, the child is improving. You can go to the non-rebreathe mask, go for the venturi mask, face mask, nasal pause. So rather than try to reduce the flow on high flow, it's better to change the device as you did for escalation, right? So you have de-escalate, change the device. So no point using, initially you are using 2 per kilo in high flow nasal prawns. When the child is improving, don't use 1 per kilo. So you are wasting your oxygen. So you have to change the oxygen delivery device. So again, the same slide. So these are the minimum flow. Nasal prawns, it should be 1. Face mask oxygen, it should be 5. Venturi mask, depending on the venturi valve. Non-rebreathe mask, 10 liters per minute. High flow nasal prawns, it is 2 liters per kg per minute. Right. So then about the multisystem inflammatory syndrome in children. This was detected in 2020 April, first in UK. So they have given this name as PIMS-TC. In other words, a pediatric inflammatory multisystem syndrome temporarily associated with COVID, SARS-CoV-2. So it's a PIMS-TS in UK. So then in US, so they have given a separate name for the same disease. It's called multisystem inflammatory syndrome in children, MIS-C. So then the WHO has selected the MIS-C. So in Sri Lanka also, we are using the name as MIS-C. So this is the summary of MIS-C. So usually this is 2 to 6 weeks after acute COVID infection. So they will develop fever with mucocutaneous symptoms, rash, conjunctivitis, red or swollen lips, strawberry tongue, myalgia, swollen hands, feet, and cervical lymphadenopathy. So what is happening? So this is 2 to 6 weeks after COVID. The important thing is sometimes, most of the time, in children, COVID is an asymptomatic disease. So nobody knows, even the parents doesn't know whether this child got COVID or not. And they will develop sometimes only the mild cough and cold. Nobody is aware. So that is important. So you will not get the clear-cut COVID-19 past history when you're dealing with MIS-C. So this is what happens in other countries. You can see, so this is the COVID cases. Whenever you are having a COVID, surge of COVID cases, the MIS-C surge will follow. That is obvious. So this is happening after 2 to 6 weeks of COVID. So obviously, when you are having more COVID patients, you should have more MIS-C patients after about 2 to 6 weeks. So initially we thought that this is only in children. Now we know that this can happen with even in adults. We call it MIS-A, and it can happen with neonates. We call it MIS-N. So this is what happens in MIS-C. It's rare. The incidence is about 1 in 5,000. Usually their age is 8 to 11. They are obese, previously well, and mortality is about 2%. In Sri Lanka, first case was detected in this year, early part of this year. More than 80 children we have managed at MICU LRH. So youngest is 2 months, the oldest is 17 years in our ICU. Below 12 years, 78. Male preponderance is there, about 60%. We had about, unfortunately, 3 deaths. And this is very important understand. So the worldwide MIS-C incidence is 1 in 5,000. So we have managed at least 80 patients in our ICU. So we think more than 200 cases we have managed over the all over the country. So you can think. So if 80 is 1 in 5,000, the total COVID infection children should be 4 lakhs. If 200 is 1 in 5,000, so more than 1 million COVID infected children should be there in the society. So this is that we are dealing with the tip of the iceberg. So most of the patients are undetected in society. That's the reality. So pathophysiology is not well understood. We think it's autoimmune disease. There's an abnormal immune response to virus, unbalanced cytokine responses, vasculitis, endothelial damage, and thrombosis. And these are the clinical features. Usually this happens 2 to 6 weeks after COVID. Patient will have fever, mucocutaneous symptoms. You can have rash, conjunctivitis, red or swollen lips, strawberry tongue, myalgia, swollen hands, feet, cervical lymphadenopathy. So this is the typical rash in MIS-C. You can see that this is one of our patients. It's a palpable vascular type of rash. So there's red, swollen eyelid and red patches of the nose. It can happen anywhere in the body. So other important clinical features, the GIT involvement is very common. They can have abdominal pain, vomiting, diarrhea, sometimes mimicking appendicitis. 2 of our patients have undergone the surgery thinking that it's appendicitis. So that is very important. Severe abdominal pain these days may be due to MIS-C. So these are the these published data. Pediatric cases. This was published in last year, October. GIT symptoms were 87%, fever 82%, cardiac disorders 75%, skin and shock around 70 to 60%. So this is our data. 80 cases, youngest is 2 months, 78% below 12 years. Mortality now it's reached to 5.8. These are the common symptoms. They had fever, CVS involvement, GIT, eye, skin, lymph node, and respiratory symptom, respiratory system involvement as CNS also there. The commonest is fever, then cardiovascular system, then GIT. So cardiovascular manifestations, the commonest is hypotension. Most of them presented with shock. These are ICU admissions, elevated troponin and abnormal echo, only 10%. And GIT manifestations, abdominal pain is the commonest, vomiting and diarrhea also there. So inflammatory markers, the CRP is high, ESR is high, D dimers are high, ferritin high. So for the COVID diagnosis, the rapid antigen was negative. This is post-COVID syndrome. PCR sometimes positive, and CT value is around 30. That means it's suggestive of a post-COVID status. And antibodies are positive in about 60%. Right. So with this background, so now we try to diagnose. This is very, very important. How to diagnose this MIS-C. So patient should be below 21 years. Fever should be there for more than 3 days. There should be inflammatory markers. No other causes of inflammation, and evidence of COVID-19 is there. That means positive PCR, positive antibodies, direct contact history, something like that. So these 5 things are essential. Patient should be below 21 years, fever more than 3 days, elevated inflammatory markers, no other explanation for these elevated inflammatory markers, and evidence of COVID-19. If they are there, then we have to look for 2 of the following: skin, eye, hypotension, shock, myocardial dysfunction, coagulopathy, GIT problems. So importantly is all these 6 parameters should be there for you to diagnose MIS-C. So below 21 years, fever more than 3 days, high inflammatory markers. There's no other explanation for this high inflammatory markers, evidence of COVID with 2 clinical symptoms. So that is very important. Nowadays, people are overdiagnosing MIS-C. So just because you are having hypertension, it is not MIS-C. Just because you are having myocardial dysfunction, it's not MIS-C. Just because you are having rash, it's not MIS-C. So in future, so you will see more and more cases of MIS-C. And not only that, more children will be antibody positive. I have shown you at least about 4 to 10 lakhs of patients, pediatric patients, should be hidden in the society. So they will come for something else. So then, if you do the test, the antibody will be positive. And that will be a problem. I'll come to that in a minute. So evidence is changing. So needs regular updates. Just because you read about MIS-C now, don't think after 2 years, you know everything about MIS-C. And this is very important. Don't miss MIS-C. So because children, COVID-19 is non-specific symptomatology. So sometimes nobody knows that these children had COVID. And you have to consider MIS-C, especially these days, fever and abdominal pain, particularly if they develop conjunctivitis. So there will be overlapping symptomatology in MIS-C. It may be sepsis, it may be toxic shock syndrome, it may be myocarditis, meningitis, all these things are behaving like MIS-C. So all the children who are ill, the differential diagnosis should include MIS-C nowadays. And especially if your patient is 8 to 10, 20 years, well-grown, fever more than 3 days, severe abdominal pain, rash and conjunctivitis, unless proven otherwise, this is MIS-C, especially who are working in surgical wards. So remember, the child present with severe abdominal pain, so your differential diagnosis definitely should include MIS-C also in these days. And this is also very important. Don't miss the other common diseases. So MIS-C is a rare disease. I told you it is happening in 1 in 5,000 COVID positive children. So we have some more common diseases. So don't miss them. So we have seen meningococcal sepsis, managed as MIS-C. We have seen COVID positive urticarial rash, managed as MIS-C. We have seen dengue hemorrhagic fever, managed as MIS-C. Not only that, we have seen one case of chlorine inhalation ARDS, managed as MIS-C. All the cases that you have seen are not MIS-C. So common things are common. So don't overdiagnose MIS-C. MIS-C is a diagnosis by exclusion. So strictly go through the WHO definition. I have told you, below 21 years, fever more than 3 days, high inflammatory markers, no other explanation for high inflammatory markers, COVID positive history with 2 clinical symptoms, clinical parameters. So strictly as per WHO definition, other causes of inflammation and infection should be excluded. So in future, I have told you, many patients will come with antibody positive. So there will be patient with dengue hemorrhagic fever with COVID antibody positive. There will be patient with leptospirosis with COVID antibody positive. There will be patient with septic shock with COVID antibody positive. So remember, so please don't overdiagnose. So all the cases that you see are not MIS-C. Right. So in our ICU, this is what happens. We are managing, this is our ICU, the COVID side. We are managing one-to-one care, one nurse bedside always. All the needed procedures are done, including aerosol generated procedures like nebulization, hyponasal pulse, intubation, non-invasive ventilation, invasive ventilation, high flow, high frequency oscillatory ventilation, IC tube insertion, PD, resuscitation. Basically, care is similar to any other child, but with full PP. You can see they're using full PP. You're doing the equal care, the COVID positive and COVID negative. So the important thing is none of the staff member got the infection from the patient. That is important. You can manage patient. You can do all the aerosol generated procedures with PP without getting the disease to yourself. That is very important. So thank you very much. If you have any questions, I can answer. but otherwise you can move to the next lecture. Yeah, there are two questions, so I can answer them in there. So, can antibodies become negative in MIS-C? Yes, sometimes these are not 100%. So, sometimes antibody may be negative, but the other something related to COVID should be there. That means either rat, either PCR, or antibodies, or contact history. So then. Our unit got 2-3 patients during the last 2 months, but initial the investigations are mislead only, then got to thought about MIS-C. If there any of confirmation, the diagnosis of MIS-C, how can we differentiate it from Kawasaki? So I think I have answered that question. So there's a criteria, WHO-led criteria are there. So you have to stick for that. So I have mentioned about 6 parameters below 21 years, fever more than 3 days, high inflammatory markers. There's no other explanation for these high inflammatory markers with COVID history positive something and to clinical symptoms. So that is criteria. And then how can we differentiate it from Kawasaki? So good question. I think you can get the we have prepared management of multisystem inflammatory syndrome in children is there in the college website. So you can download it with that, or you can ask for any pediatrician, so they will have the soft copy of it. So all the information is there to differentiate it from Kawasaki. Or so say that the Kawasaki is a disease with the age is not like this. So this stage, like 10-15 years, we are not suspecting Kawasaki. Kawasaki is an infant disease. So that is one thing. And when doing the echo, the changes are different, slightly different with the Kawasaki. But having said that, the management is same. So you don't have to worry much. So there are some subtle changes, but management is same. Yeah. What about the prognosis? Excellent prognosis there. If you detect it early and treat properly, prognosis is very good. So treatment is IVIG plus methylprednisolone. So it's all these things there in the guideline. So when you treat early, the prognosis is very, very good. So far we have about 200 patients all over the country. I think less than about 5 deaths. So worldwide also 2% is the mortality. So that is treatable. Is there vaccine associated MIS-C cases reported? So far there are no reported cases, but theoretically, yes, it can happen because this is antibody-mediated disease. This is inflammation due to autoantibodies. So if this is happening with the disease, there's a theoretical possibility of getting into the vaccine also. So having said that, we haven't diagnosed any vaccine-induced, vaccine-related MIS-C. But those days that we have started vaccinating these children very we were not vaccinating the children early. So we don't know related. We don't know really it is happening or not. So far, not. Can MIS-C happen during the active COVID infection period? Yes, that's a good question. So especially now I have discussed about MIS-C and MIS-A also. When you think about the adults, young adults, so what they say is even with acute infection, this can happen. So about 30 to 40% of the MIS-A cases are acute illness. So during the acute illness, this can happen. So some of these young adults, deaths, especially in Sri Lanka, when we're analyzing their presentation is like severe abdominal pain, and 2 deaths, they have done the appendicectomy before the death. So I'm not very sure, but this can happen. So world literature shows that acute infection also can cause MIS-C. how do you manage misty? This is not a lecture to go through this, but anyway, management based on the specific management is on methylprednisolone and IVIG. How long do you have to continue aspirin? At least for 8 weeks. All these things are in the guidelines. So if the echo and the cardiac involvement is minimum 8 weeks, but if it is not there, you have to continue more. Okay, so we'll stop the lecture now. So we have answered most of the questions. So thank you very much.
Right. Thank you, sir, for the detailed history on detailed lecture on latest on COVID management and that interactive session of answering the questions. So next up is lecture by Dr. Manjula Hevadikana, consultant intensivist at LRH on oxygenation and carbon dioxide elimination. Over to you, sir. So can you hear? Yes.
Yes, Roshan, still I can't share my screen. I think Nalini is still in.
Check. No, he's not, sir. So you can share now.
Roshan, I can't access my computer to sharing.
Okay. So have you
I'm
opened
somewhere
the?
else. Yeah, I'm logged in. I'm logged in.
Yeah, I know.
Actually.
But have you opened the what do you call the PowerPoint presentation?
Yeah, I have done it.
Okay. Then, sir, then press share. Then share sound, optimize audio clip, and share. So you have to click the particular one. It has to be
give me
blue.
a second. Give me
Okay,
a second.
sure thing.
Right, let me try. Okay.
Right. Excellent. It's coming up.
Can you see, Roshan?
Yes, yes. So might have to make it full screen. Yeah.
Yep.
Perfect.
All right, I think my internet is a little unstable, so I will do the lecture without the video. So good morning, everyone. Sorry for the delay in coming on to this lecture, because this lecture supposed to be before the Nalin's lecture, and there has been some technical issues. So anyway, let's start this lecture. So what I want to lecture on you guys at this moment of time is about oxygenation in critically ill children, but this is applicable to adults as well. So outline of this will be on why oxygen and why we need oxygen, and of course the oxygen cascade from outside environment up to its main acting point of mitochondria, and also then we will discuss certain management aspects of oxygen deficiency, and we will touch a little bit on oxygen delivery devices as well. Nalin also touch certain aspects of these oxygen delivery devices. So oxygen, we all need oxygen. So why we need oxygen is because it is needed for aerobic metabolism. So as this graph shows you, you can see that whenever you have oxygen, there is aerobic metabolism. An advantage of aerobic metabolism over anaerobic metabolism is that it produces about 38 molecules of ATP, and it doesn't produce adverse things like lactate. So whenever oxygen is deficient, there could be potentially anaerobic metabolism which will produce less ATP, and in addition it will produce unwanted and harmful things like lactate. Right. So when we talk about oxygen and when we talk about giving oxygen and also troubleshooting oxygen deficiency, first thing we need to look at how oxygen goes to its intended place of mitochondria. Okay. So as Nalin explained to you in the first lecture, in the earlier lecture, oxygen needs to come from a source. There has to be oxygen source, and oxygen source could be nasal pumps, ventilator, high flow device, or whatever. It needs to come from a source, and this first needs to go into the alveoli. So from outside or the oxygen source, it needs to go to the alveoli, and then certain things that interferes or this flow from outside oxygen source into the alveoli depends on certain things. One is the pressure. So there has to be a pressure difference if gas flow to occur. So which means either the pressure should be less in the alveoli comparative to the oxygen source or outside, or this should be higher comparative to the alveoli. So negative pressure ventilation, when we are breathing, what we do is we create a negative pressure in the lungs comparative to the outside. And in positive pressure, what we do is we create the ventilator create a positive pressure or higher pressure here comparative to the alveoli, so that there is a gas flow. And also oxygen inside the alveoli will also depends on the concentration of oxygen here. So now if you are giving 50% oxygen, that's what reaches the alveoli. So if you want more oxygen in the alveoli, of course you have to increase the concentration. And not to a great extent, but to a lesser extent, the volume of gas flow, the amount of volume, we call it tidal volume in terms of breathing, how much a particular breathing has sent, how much volume a particular breathing has sent to the alveoli. So that is tidal volume, or the volume, and also the rate. Say for example, a child is hypoventilating, so the volume is not enough, or the rate is not good enough. So that sort of case, not actually initially, but at least later on, if we don't rectify this issue, can cause oxygen deficiency. So remember, from oxygen source to alveoli, we need a bit of a pressure difference, and the oxygen enters the alveoli also depends on the concentration and the breathing volume and the breathing rate. Okay, so from alveoli, it needs to go into the arterial blood, and this actually depends on diffusion, because between the alveoli and the vascular side of the alveoli, there is a alveolar capillary membrane. So gas inside the alveoli needs to go through this alveolar capillary membrane, and the process of going through this alveolar capillary membrane is called diffusion. So any issues with the alveolar capillary membrane can affect the diffusion, and then that may be the reason for oxygen deficiency in your patient. So examples are chronic conditions like alveolar fibrosis, and other issues like say pulmonary edema with a lot of fluid in the alveolar capillary membrane will also affect this process. And then there is a thing called VQ mismatch, and we'll come to that in the next couple of slides. So V in VQ is ventilation, Q is flow. So ventilation is gas entering the alveoli, Q is the flow of blood across the alveolar capillary membrane. So this has to be matched. So whenever there is a mismatch, the patient can have oxygen deficiency. And there is another thing called shunt. Again, we will explain this in the next couple of slides. Shunt, if I can give you an example, now think about a cyanotic congenital heart disease, tetralogy of fellow patient. Whatever comes to the right side of the heart, rather than going into the lung through the VSP, or the hole between the right ventricle and the left ventricle, will be shunted towards the left ventricle. So now left ventricle will not only have 100% saturated blood, but also this less saturated or no saturated, less saturated shunted blood. So ultimately that will reduce the oxygen saturation and the oxygen amount on the arterial side of the blood. Then hello. I'm lecture again. So whatever comes to this arterial side is not intended to be there. So it needs to be transported to the tissues, right? So, so this involves having blood, having oxygen in the blood, which depends on certain things, which depends on the amount of hemoglobin saturation, and what amount of oxygen one hemoglobin molecule can carry, right? Then not only this, but this amount of oxygen which is in the blood needs to be carried to the tissues, and this is done by the blood flow. And this blood flow we are talking about is actually cardiac output, right? So the oxygen that comes into the arterial blood needs to be carried, and this is carried by the hemoglobin and also by the dissolved oxygen. But this dissolved oxygen is usually negligible. So what we are actually concentrating on the hemoglobin, and also this needs to go to the tissues, and how it is done is by the cardiac output. Then entering the tissues or reaching the tissues is not enough. This needs to be extracted and transported towards the mitochondria, and there it needs to be utilized. So if the tissues are unable to extract, or if the mitochondria is unable to utilize, even when the oxygen is supplied to this area, the patient will have signs of oxygen deficiency, right? When we talk about oxygen deficiency, there are two terms that you need to understand. One is hypoxemia. So whenever there is a suffix of mia, it indicates that blood. So hypoxemia means there is deficient oxygen in the blood. Say, for example, now you think a healthy person should have an oxygen amount of 100, PaO2 of 100 in the blood. And if this patient is having a PaO2 of around 60 due to some reason, we can say that this patient is hypoxemic. And another way of defining hypoxemia is by way of expressing the saturations. So normally you expect the saturations to be somewhere around 100%, but in certain people, this may be much less than that. Say, for example, it may be something like 85%. So you can term these patients are having hypoxemia. But this is quite different to the next term. Next term is hypoxia. Hypoxia is lack of oxygen, not in the blood, but at the tissue level. So from this cascade, now you can understand that even when oxygen is there in the blood, which means the patient is not hypoxemic, patient still can have lack of oxygen at the tissue or the mitochondria level. So the patient is hypoxic, and more on that when we discuss the next couple of slides. So if so, from this, what are the practical points that we can get? So if the patient is having hypoxia, not hypoxemia, hypoxia, you need to, as clinicians, look into whether this is due to a problem of oxygen delivery to the alveoli. Now we decided we have already expressed what are the causes or what are the things that is determine the delivery of oxygen from oxygen source to alveoli. So you need to see whether those are okay, and then diffusion. Okay, so there are certain things I have already explained that can affect the diffusion of oxygen from the alveoli to the capillaries. Then thirdly, is it because this oxygen that goes into the blood, the blood is unable to carry it? So is it a problem of hemoglobin? Okay, then so even when the oxygen is there in the blood, is it not being delivered to the tissues? So is it a cardiac output tissue? And is there a problem of oxygen extraction? So tissues are getting oxygen, but is unable to extract. And lastly, is it a problem of utilization? So oxygen is delivered up to the level of mitochondria, but mitochondria is unable to utilize. Now, so you can see that evaluating and trying to have a work plan or the treatment plan for hypoxia is not as simple as starting oxygen, because hypoxia may be because of different reasons. So you need to evaluate the patient in oxygen's journey from outside up to the mitochondria. Okay, so let's elaborate what we have discussed up to now in the next couple of slides. Right, so to alveoli, I said, of course, you need to have a pressure difference, and also you have to have a patent pathway for this oxygen to go. So you have to think about the airway, and if the patient is intubated, whether these pathways are clear. So airway is clear and the ET tube is clear. And also I said, sometimes the tidal volume, the volume that enters the alveoli, plus the rate of the volume delivery to this alveoli is also important. So you have to say whether this child is apneic or whether the child is actually hypoventilating. Then amount of oxygen or the concentration of oxygen. So you have to say whether your FiO2 is adequate. FiO2 is fraction of inspired oxygen. So if you are on 25% oxygen, so there may be a case to increase FiO2 to 60%. And whether the oxygen flow rate is enough. Nalin said that for certain devices there is a minimum flow rate. So are you below this minimum flow rate? Okay, and whether this pressure difference is adequate, or whether the patient has a higher pressure inside the alveoli rather than the outside. So impairing delivery of oxygen from outside to the inside. Okay, right. Then now what I have shown here, this is an alveoli. So of course alveoli will have carbon dioxide and oxygen, and this is the alveolar capillary membrane, and these are the vessels which is in continuity with the alveoli, so which has a pulmonary artery and which has venous blood, and the pulmonary venous vein which has well saturated blood. So venous blood which is desaturated will enters and be in contact with the alveoli, and the gas exchange occurs here, and when it leaves the lungs through the pulmonary veins, it is fully saturated. So blue blood here and red blood there. Okay, so this is what normally happens if we take a single alveoli, right? So then there are certain things which affects oxygen from going from the alveoli into this vasculature, pulmonary vasculature. And one thing we have already discussed, that is a problem of alveolar capillary membrane. Okay, so let's look at the alveolar capillary membrane. So this is the alveoli, and this is the vessel, and this is alveolar capillary membrane. So there is a little bit of distance between the alveolus and the pulmonary capillary bed or the pulmonary vessel. And due to any reason, if this distance increases, say for example edema, it is going to affect this gas section. And sometimes this alveolar capillary membrane is not smooth like in a normal situation. So this may get fibrosed because of chronic lung disease and other different reasons, and that will also again affect oxygen from going from alveoli into this pulmonary vessel. Okay, so that can of course cause hypoxemia in your patient, and then as a result the patient might have hypoxia. Then we talked about VQ mismatch. So let me explain VQ mismatch using these figures. So look, this is a normal alveolar. Now I have shown you two alveolar units. So this is the airway which are going into this alveolar unit, and these are the vessels. Now you can see this is the arterial lane which contains venous blood, and it goes through the alveoli and it gets oxygenated. So many of alveoli does this, and then ultimately the vessels from these many alveolar units gets together to form the main pulmonary vein. So let's assume that this is a main pulmonary vein. Okay, so this is a pulmonary artery, and it gets oxygenated and then ultimately enters the pulmonary vein. right? So look at this figure, right? So this figure, as you can see, there is a problem of this alveoli. Alveoli is filled with water, and the condition that that fills the alveoli with water is pneumonia. One is pneumonia, the other one is pulmonary edema. Okay, so what happens now? Venous blood comes here and is in continuity, is in connection with this alveoli. But what has happened to this alveoli? This alveoli doesn't have enough oxygen, so hardly any gas exchange occurs here. Right, but on the second alveoli is normal, so the normal gas exchange occurs in the second alveoli. But once it reaches the common vein or the main pulmonary vein now have 100% oxygen or blood from the normal alveoli, as well as venous blood, which is coming from this alveoli, which is diseased and no gas exchange. So your ultimate saturation and the oxygen content in this blood is less, and this is one of the examples of VQ mismatch. So here flow is there and the ventilation is not matching the flow. Okay, next one, again another example of VQ mismatch. Here, rather than the alveoli, the problem is with the airway. Okay, now here the airway is constricted due to some reason, maybe secretions, maybe anatomical obstruction, maybe external compression, and as a result, like in the first case, there is hardly any oxygen. So there is some more oxygen than this one, but that is not good enough to saturate or oxygenate this venous blood like in a normal alveoli. So ultimate result here is not very red blood, blue blood. Okay, all right. So this is what we call VQ mismatch. Right. So hello, Pradeep, I'm in a lecture. Right. So so in the shunt, now we talked about the VQ mismatch. So it's kind of an intrapulmonary shunt. So what you call by shunt is venous blood without getting oxygenation comes onto the arterial side. So that is what we call about what we meant by shunt, right? So if you sort of go back to the VQ mismatch, and you will realize that actually what happens in VQ mismatch is venous blood without getting oxygenated coming onto the systemic arterial side. So it's a kind of shunt, but this is not the shunt that we are trying to talk about. This shunt, when we talk about this kind of shunt, this is intracardiac shunt. So in this example, you can say there is a hole between the right ventricle and the left ventricle. We call this VSD, and rather than going into the pulmonary artery and into the lungs and getting oxygenated and coming on to the left side, what happens to this venous blood? They at least part of them goes towards the left ventricle, and it gets mixed with the blood that is coming from the lungs and the left atrium. So ultimately you will be having not purely oxygenated blood, but a mixture of oxygenated and deoxygenated blood. This is an example. This example is of a tough child, tetralogy of fallow child. Okay, so this is what we call shunt. So if your patient doesn't have adequate amount of oxygen on the arterial side, and as a result, if the patient is hypoxic, it may be because oxygen not coming into the alveoli. So evaluate the journey of oxygen from oxygen source into the alveoli, or it may be because of a problem in the alveolar capillary membrane. So oxygen is there in the alveoli, but it's not going into the the pulmonary vessels, or it may be a VQ mismatch, which is a shunt, kind of a shunt in the lungs, where some of the alveoli are oxygenating, but some of the alveoli are not oxygenating. So together they cause desaturated blood or less oxygenated blood, or it may be because of a pure shunt inside the heart. Okay, So these are the things that you need to evaluate when you try to determine what the cause of hypoxemia in your patient, and which might even cause hypoxia. Okay, right. Now when this oxygen enters the blood, it has two options. One is to get hold on to the hemoglobin, which is the more efficient way of containing oxygen in the blood, or dissolving, right? So at the moment I'm not discussing about the dissolvement of oxygen, because the amount that is gone by way of dissolving is very small, and I will explain why. So let's put some numbers. If the hemoglobin is 15, then usually one hemoglobin, when fully saturated, 100% saturated, will carry about 1.34 ml of blood. So one here is for the 100% saturation. So amount of hemoglobin is 15. So this will carry about 20.1 ml of blood per deciliter of 1 ml of oxygen per deciliter of blood, right? So this is the amount of oxygen carried attached to hemoglobin, right? But dissolved, right? So dissolved amount of hemoglobin is oxygen is 0.003 ml into 100, so which is about 0.3 ml per deciliter of blood. So you can see attached to hemoglobin it will be about 20, whereas it will be 0.3 ml in the dissolved form. So you can fairly deconsider the amount of dissolved hemoglobin. So in this lecture, I'm concentrating on hemoglobin, which is oxygen, which is bound to hemoglobin. Okay, right. So whenever oxygen is there in the blood bound to hemoglobin, now that is not what we want. We want this oxygen to be delivered to the tissues. So this is called oxygen delivery. So oxygen delivery depends on two things: oxygen content. Oxygen content is the amount of oxygen in the blood. We said that this is basically the amount of oxygen that has been attached to hemoglobin. Then this has to be carried. This is done by the cardiac output. So the amount of oxygen actually reaching the tissues will depend on two things, and that is the cardiac output. We need cardiac output, and also amount of oxygen attached to the hemoglobin. Okay, right. So cardiac output, on the other hand, will depend on few things, and we all know and three basic things that determines the cardiac output is preload, which is the amount of fluid in the right side of the heart, contractility and how vigorously heart contracts, and the afterload, the resistance against which the heart has to pump out. Okay, so if you have optimum preload, good contractility, less afterload, there will be good cardiac output. So if you want to improve the cardiac output, in other words, if your patient's cardiac output is less, then you have to look at the preload, and if the preload is not good enough, you have to give some fluid, and you might have to augment the contractility by using contractility enhancing agents like ionotropes. Then you might have to come down on the afterload if this is high by using either pulmonary or systemic vasodilators. So remember, oxygen in the tissues not only needs oxygen in the blood but also the cardiac output, right? So just a practical point here, and sometimes whenever the patient has hypoxia, our general tendency is to increase oxygen. So how you increase oxygen? You might increase the FiO2, and if the patient is being ventilated, you might increase the ventilator pressures. So what happens when you increase the ventilatory pressures? And we know when you increase the ventilatory pressures, that will sometimes increase the intrathoracic pressure. So whenever you increase the intrathoracic pressure, that will affect the preload. So when you try to increase the amount of oxygen in the blood by increasing the ventilation, sometimes what you will do is inadvertently you will reduce the preload, and then it will affect the cardiac output. So oxygen will be there in the blood but may not be delivered to the tissue. So whenever you are increasing or you are touching the ventilator, think about this aspect as well, because what we want is not the oxygen in the blood, but we need oxygen in the oxygen at the level of the tissues and at the level of the mitochondria, right? Again, just to highlight this, another factor. Now, this is the arterial side, this is the venous side. So blood is pumping fully saturated oxygen. Let's say that the saturation is 100% in this oxygen, and this is the tissues. Now, tissues has taken about 30 of oxygen, and you can see that on the venous side there will be 70 of oxygen. So these are just numbers. So assume that these are actual values. Now, if you don't deliver adequate amount of oxygen to the tissues, because for the function it needs 30, what it will do is it will extract more. So here, when the 100 is delivered, it extracts 30. So there will be a balance of 70 here. Now, supposing you deliver only 80, so it will still extract 30. So what will happen is on the venous side, the blood will be bit devoid of oxygen than in the usual circumstances, right? So if it is 90, 30, and this will be 60. So you understand that this can occur until a particular period. So now in this graph, what you have seen is oxygen delivery is going down. So this number is going down and down and down. However, there is still adequate amount of oxygen in the tissue. So nothing happens. So amount of oxygen in the tissues will be the same. Oxygen delivery comes down, 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 but still the amount of oxygen in the tissues is the same, because it will extract more and more. But one particular time here in this example, 30. If it reaches the 30, we call it the critical DO2 point has reached, because below 30, this is going to go down. So if this is 25, then the oxygen needs tissue needs about 30. So there will be a 5 deficiency of oxygen. So this is going to go down like this. So when it going to go down like this, the tissues are starved of oxygen, and then anaerobic metabolism starts, and the lactate and other adverse effects starts to occur. So supplying oxygen is aimed at matching the oxygen demand of the tissues, right? So another practical point here, if you can't supply adequate amount of oxygen to the tissues, then try to reduce the need of oxygen in the tissues. Mama, if we take a life example for this, now if you are earning and if you can't match your earn to your utilization, your expenditure, then if you can't increase your income, then of course the next best thing is to reduce the expenditure. So likewise, if you can't supply adequate amount of oxygen to the tissues by any means, then of course see the ways of coming down on oxygen need of these tissues. Some examples are intubating, so that the child or the adult doesn't has to breathe fast, and work on breathing, and sedating them so that they are not moving. The oxygen necessary for those movements are less now. So those are some things that we can do if you are having problems of oxygen delivery. Right. So hypoxia and hypoxemia, I have already discussed this. Remember this. So evaluating a hypoxic patient. So just increasing the oxygen is the usual action of us whenever you see a hypoxia, but you need to look into the mechanism of oxygen from the source up to the mitochondria. I hope I gave you the necessary baseline knowledge so that you can evaluate a hypoxic patient like that. Right. So I have already discussed this. So just to go on again. So patient may be hypoxic because there is low oxygen in the alveoli, and we call this anoxic hypoxia. So patient is hypoxic because there is not enough oxygen in the alveoli. So if the patient is hypoxic, see whether this is anoxic hypoxia. So what you need to do in this case is you can increase the FiO2, and then you can wash out the carbon dioxide. You can optimize the ventilation in this sort of a situation. Or it may be because inadequate oxygen going towards the blood sites, that we said BQ mismatch. and we said another example was the shunt. So all these three will cause what we call anoxic hypoxia. Okay, so look whether there is a low FiO2. If not, whether there is any possibility of having a VQ mismatch. If not, see whether there is any possibility of having a shunt. Okay. Next thing is oxygen comes to the alveoli, it enters the bloodstream, but there is no adequate amount of hemoglobin to keep it, right? So you saw how much the contribution made by the hemoglobin to keep oxygen in the blood. Okay, so this is called anemic hypoxia, and sometimes whenever the patient shows signs of hypoxia, you might be able to overcome it by giving a blood transfusion. Right, then tissue hypoxia may be due to impaired delivery, and I have already explained this. This may be because of the, this is called stagnant hypoxia, right? So here PaO2 is normal, hemoglobin is normal, saturation is fine, but it is the cardiac output. So look for issues of cardiac output. Is it the preload? Is it the contractility? Is it the afterload? These are the three basic things. And if you sort of, evaluate the three basic things, then of course you have to go for the advanced things. Which is beyond the of this lecture. Right. So types of hypoxia, just to summarize: anoxic hypoxia, anemic hypoxia, stagnant hypoxia. Histotoxic hypoxia I didn't discuss because this is not very common. Histotoxic hypoxia is the tissues are unable to extract, or the mitochondria is unable to utilize. So these are the three most common types of hypoxia. Right. Okay, so hypoxia and hypoxemia I have already discussed, and it's good to emphasize at this point that the patient can have hypoxia in the presence of hyperoxemia or normoxemia. Say for example, your patient's lungs are good and good amount of hemoglobin is there, saturating well, so there is good amount of oxygen in the blood, so there is no hypoxemia, or it may be normoxemia, or the oxygen content may be very high, so it may be actually hyperoxemia, but the patient does not get, patient's tissues not getting enough adequate oxygen because of the cardiac output issue. So patient is hypoxic, but the patient is hyperoxemic or even normoxemic. Okay, so remember, your oxygen content or the oxygen amount in the blood may be low, may be normal, may be high in the presence of hypoxia. Okay. Right. So assessment of hypoxia clinically, we all know that. So in the respiratory system, you will see the patient is using, patient is tachypnic, patient has an increased work of breathing. In the cardiovascular system, you will see the tachycardia, and the peripheries will be constricted, and the skin will be mottled and pale, and the patient will be cyanose. And if the patient is cyanose, usually he is in peri-arrest. And when the patient is deficient of oxygen, and one of the common things we see is the patient is initially agitated, and if you don't treat it, the patient will be drowsy. So these are the telltale signs of hypoxia in your patient. Let's skip this slide. And assessment of hypoxia using biochemical methods. The common thing is the blood gas. So when you do a blood gas, you can get an idea about the hypoxemia. How you can get an idea about the hypoxemia? Because the blood gas will give you amount of oxygen in the blood. So this is called partial pressure of arterial oxygen. So this will, if this is less than what is expected, we can call it that this patient is having hypoxemia. Usually PaO2 has to be interpreted according to the FiO2 that we give. Say for example, you can have a patient who is having 100% saturating, who is having PaO2 of 100, but we are giving 100% oxygen. We are giving 100% oxygen. So this is quite contrast to having a patient who is having 100% saturation, PaO2 of 100, but on room air. Okay, so always therefore interpret PaO2 in the context of FiO2. Say if you have to increase the oxygen flow rate, tell your colleague when you are handing over that I have to increase the oxygen delivery to this patient, and his PaO2 is after that. Okay, oxygen index will also incorporate mean airway pressure, so I have no time to discuss this. So remember that there is an entity called oxygen index as well. So if you have time, go through the internet. There are many sites that explain what is oxygen index is. So this is quite different to hypoxia. So this is the evaluation for hypoxemia. Remember, patient may not be hypoxemic, but still patient be hypoxic. And what are the signs of, or what are the features of hypoxia in the blood gas? And this is the venous saturation. If you do a venous blood gas, or high lactate or unexplained metabolic acidosis. So if you do a venous gas, if venous gas is less than 70%, or if you do arterial gas, if the lactate is more than normal, or if there is unexplained metabolic acidosis, not because of any metabolic disorder, you have to always think that this patient may be hypoxic. Okay, so management of hypoxia, depending on the cause. So remember, I'm not going to, because I have already discussed this. So depending on the cause, so see whether this is anoxic hypoxia or hypoxic hypoxia, or stagnant hypoxia or anemic hypoxia. And then depending on the cause, think about increasing the oxygen delivery, think about the increasing the hemoglobin, or improving the cardiac output. So these are the things that that you need to do in the management of hypoxia in your patient. So whenever you are managing a patient who is critically ill, there are certain important things that you need to remember. So better is the enemy of good. Why I say better is the enemy of good is, now think of a situation where your patient is having bad lungs, you are intubated and ventilating, and if you try to achieve normal PaO2s and normal saturation in this patient, what you will do is you will actually damage the lung by your ventilation itself. So always have sufficient amount of oxygen, not better amount of oxygen, right? If you cannot supply, I have already explained this, if you cannot supply enough oxygen, so see whether you can reduce the need of oxygen, right? And then address the root cause and improve tissue oxygenation rather than the blood oxygenation. So oxygen delivery systems, I think the Nalin already discussed this. So basically there are two varieties, low flow systems and the high flow systems. Simple mask, nasal prongs, mask with a reservoir, non-rebreathing bag, and the oxygen hood are the low flow ones. The high flow ones are the true high flow nasal humidification devices, NIVs, and the ventilator, and also mask with a venturi, right? So you need to understand the limitations of these devices. I think Nalin already addressed this, and you need to understand how this works, and in which sort of patients you should use this. Okay, so in summary, so there are two different entities, hypoxia and hypoxemia. Hypoxia is more important than hypoxemia. Hypoxia can occur in the presence of hypoxemia, hyperoxemia, and normoxemia. Then when you are managing a patient, or when you are evaluating a patient, reduce the need for these if you can't deliver enough oxygen, and know your oxygen deliveries, and remember that oxygen is a medicine, so careful when you use it. Thank you very much.
Right. Thank you very much, sir, for the detailed lecture. So
we are short of time, and I can answer a couple
yes.
of questions if there are burning questions.
Yeah.
Okay.
Right. Thank you, sir. Seems like no questions. Right. So next up is lecture demonstration of pediatric cardiac arrest, right, by Dr. Birunti Sivakanthan. Over to you. Dr. Birunti, can you hear? You have to unmute. Right. We have made you a co-host. You can unmute yourself.
Thanks. I must be tired, and this is a short lecture on cardiac arrest in children. I'm Dr. Brinda, working at Columbus South Teaching Hospital as a medical officer, and I'm an instructor in the Advanced Pediatric Life Support course, and this is the lecture from the Advanced Life Support course, Australia. So, managing children with cardiac arrest is anyone in the group. This is an interactive session, so anyone in the group can unmute yourself and answer the chat box you can use to answer. Anyone managed a child with cardiac arrest? Any answers? Chat box. So usually managing a child with cardiac arrest, they will come with different problems, but its common reason is usually respiratory reason or circulatory reason. So you should be able to identify the cause and you should be able to treat it. So if you go through this lecture, it will take you through a practical process so that you can immediately attend the patient and you can immediately treat it. So most of the time we do basic life support and airway and then third lecture as this, but because of the time problem, we are going for the cardiac arrest lecture first. I will try to coordinate with those two lectures, okay? So to understand the structured approach to cardiac arrest, so in emergency, any structured approach will help you all to intervene immediately. So if you know it is the order, then you can go and if you have a structure, you can go and immediately intervene in any emergency so that you should know how to approach a cardiac arrest in order. Then to describe the protocols. The protocols are made for the junior doctors to intervene and to start the process. So it will be a standardized protocol used by Australian and New Zealand version of Advanced Pediatric Life Support. Different countries uses different protocols. It will change with time. So every 5 years, usually these guidelines are reviewed. So you should be able to update yourself so that you can give a proper care to the patient. So this protocol is based on Australian New Zealand version. This is used in Sri Lanka. So you all can use this protocol to resuscitate any child. To introduce the drugs and equipment used in cardiac arrest. So drugs, emergency drugs, you should be able to know the doses and the routes and the side effects which cause when you are using the drug so that you can use the drug confidently. And the equipment, so if you know the equipment and handling, Dr. Nalin has told you how to use the equipment during the hypoxic part. So likewise, during the emergency cardiac arrest management also, you should know the equipment strategies, how to use that equipment, and you should be able to use it effectively to get the outcome 100%. So we will introduce some of the equipment. Right, so if you found a patient arrested, so when you think a patient is arrested most of the time, if they are not breathing, if they are not responding to your voice, so if you think there is no pulse or pulse rate less than 60, you will think that patient is in cardiac arrest. So in that situation, what you will do you will start the basic life support. That is the immediate treatment you have to start. This is without any equipment. You are starting to maintain the vital organ function. So that is called basic life support. You will have a separate lecture later on. So once you establish the basic life support, that goes like airway, opening the airway and maintaining a patent airway, and then giving a high flow oxygen. So most of the pediatric arrest is due to oxygenation. So we should not forget that. That is why the airway and breathing starts first. Then you will go and assess the rhythm so that you need the cardiac monitor. So if you go through this order, you will reach the Rhythms, right? So basic life support starts as DRS and open up the airway. So danger, look for danger, check for responsiveness. If there is no responsiveness, immediately send for help. So call your emergency trolley, and then you have to put the child in supine position and open up the airway, look, listen, feel, and check for breathing. If there is no breathing, immediately establish 2 rescue breaths. After giving 2 rescue breaths, you need to check the pulse. So pulse check is at carotid in a bigger child. Smaller child, children, infants, you can check the brachial or femoral pulses, not more than 10 seconds. So if there is no pulse or if you have a doubts, look for signs of circulation. So if the patient is unresponsive, color is not good, then you treat that patient as in arrest and immediately start your CPR. So CPR consists of 15:2 ratio. So that is all the children, you have to start it in this manner. And your rate should be 100 per minute. And then you have to maintain 1/3 of the chest compression. This will be discussed in detail in the BLS lecture. So this, while you continuing this CPR, so 15:2, 15 compression to 2 breaths, you will attach the monitor. So cardiac monitor with defibrillating facilities should be attached to the monitor. And you will stop, once the monitor is ready, once the rhythm appears on the monitor, you will stop the CPR for not more than 10 seconds and you will assess the rhythm. So when you are assessing the rhythm, you will get 2 types of rhythm, that is shockable rhythm or non-shockable rhythm. So we will come back to these rhythms later. Before that, we will see how this patient can go into arrest. So there are causes which are reversible, will cause arrest in children or even in adults. So those are called 4 H's and 4 T's. So when we think about 4 H's, that is hypoxia, hypovolemia, hyperkalemia or hypokalemia, any metabolic causes, and hypothermia. So if you think about these causes in children, common cause is hypoxia. So how will you detect hypoxia in children? Any idea? Anyone wants to talk? When will you suspect hypoxia in children? There's a big lecture on hypoxia. Hypoxia in children, anyone would like to talk? Or can they unmute the mic or can't? You can put it in the chat box. So once you see the look, listen, feel, if there is no chest movement, you have to think about whether there is oxygenation or not. So if there is block in the airway or if there is no breathing, so we won't be able to, we will be guessing hypoxia in children. So you want, once you find out the airway, you open up the airway, then what you will see, look, listen, feel, and if there is no chest movement in the patient, or if you are not hearing any air, you will think, okay, the patient is not getting any breaths inside, so any air inside. So that will tell you the patient is in hypoxia. So immediately what you will do is you will start your resuscitation of airway and breathing. So airway starts with positioning, opening up the airway, and then you will put oropharyngeal airway and immediately start bagging, right? Self-inflating bag is used in a non-breathing patient. So immediately start your bagging. So smaller children, you will use 450 ml, and bigger children, you can use 1000 ml or 1500 ml to bag the patient. Make sure oxygen flow is going on and the cylinders are full. Those are the mistakes we do while we were resuscitating. And adequate seal for the mask. And while you are bagging, you should be able to see the chest expansion nicely. So if you can't see a chest expansion, then you have to move on to go to the permanent airway, that is intubation, right? So till the chest moves up and down, you have to make sure your airway is perfect, right? So that is how you will manage the hypoxic component during the arrest. So hypoxia is the leading cause for arrest in children. So it can be due to respiratory failure or it can be due to circulatory failure. So you have to search for that. So when it comes to circulation, hypovolemia may be the leading cause for circulatory problem. And so what are the reasons the child can present with hypovolemia? When will you suspect the cardiac arrest is due to hypovolemia in children? Answers in chat box if you all can. Okay, so hypovolemia mainly when you have to suspect history, isn't it? So you have to think about vomiting, diarrhea, poor feeding in smaller babies, isn't it? And trauma, right? So all these examples you have to ask from the history, and you should be able to treat the hypovolemic component. So in arrested child, you won't be able to feel a pulse, isn't it? So capillary refilling time anyway prolonged, color will be pale, body will be very cold. So those are clues, but history will give you more towards reason for hypovolemia. So in that case, what you have to do is you have to give fluid volumes, so that 20 ml per kg, and you have to give it as a bolus. So tachycardia, yes, pulses, electrical activity if you see in the monitor, and if you can't see a child with consciousness, color will be pale, then you can think about whether he is in pulseless electrical activity, and you can give the resuscitation immediately. So hypovolemia always suspect and give a normal saline bolus. So if there is a underlying cardiac problem, maybe you can reduce the bolus volume, but reassessment is very important to fill the tank. Okay, so always think about hypovolemia in an arrested child and exclude it. Then hypoglycemia, hypercalcemia, hypokalemia. So when you are thinking about hypokalemia, diarrhea history, vomiting history, you have to replace the potassium immediately. So you should know the doses of these drugs. And hyperkalemia, potassium may be high. So you can think about some diseases, underlying diseases mostly, CKD, right? So, and burns. So these type of condition, and trauma, muscle injuries. So you can think about conditions like that, and you may need to, so seeing a tall T wave before the arrest may be a clue, but during the arrest, you won't be able to see the tall T wave, isn't it? So you have to think in terms of history, and you try to treat the hyperkalemia. So how will you treat the hyperkalemia? What is the first drug to give in hyperkalemia during the arrest? So we won't be able to nebulize here. Any drugs we can give to treat the hyperkalemia? Chat box. So it is calcium gluconate. You can give it immediately, and then that is the only indication we are giving calcium during the arrest. No other way we are giving calcium. Yes, cal gluconate we can give, but no other place for calcium gluconate because it can worsen the reperfusion syndrome, so that we are not giving the calcium. So only hyperkalemic arrest, we are giving calcium as a stabilizer. Then you can give insulin dextrose, check your blood glucose. Usually children can present with hypoglycemia. So if there is hypoglycemia, give the insulin, give the sugar first and then give the insulin. So this is how you will manage the hyperkalemia. In addition, if we know that arrested patient, there will be metabolic acidosis. In that case, we can give sodium bicarbonate to make it a little bit alkali. So that is the only place usually we are giving sodium bicarbonate and calcium. So sodium bicarbonate we can give in other places as well in metabolic problems. Like now when you are resuscitating, you establish your airway and ventilation and CPR, then you may be able to give the sodium bicarbonate as a last resort if the arrest is prolonging. Make sure that your ventilation should be perfect in order to wash out the carbon dioxide which is accumulating following bicarbonate administration. So bicarbonate indications are like that. Some drug overdoses also we are giving some bicarbonate. Otherwise, no place for bicarbonate. When you are giving these drugs, you have to make sure you can't give calcium and bicarbonate in the same IV line. And if you are giving adrenaline through the same line, you should, after giving bicarbonate, always make a flush with 5% normal saline and then give the adrenaline. Otherwise, this drug degradation can happen with bicarbonate alkalines. So next is hypothermia. Hypothermia during arrest. So if it is drowning history, most of the time hypothermia, and smaller infants, neonates, they will come with hypothermia when they are in shock. So most of the time rewarming take place, but if it is a severe hypothermia, we rewarm actively, otherwise we will maintain that. But if there is a high fever, we should treat that fever, but hypothermia, we can slowly rewarm up and they can come up to normal of about 34 degrees Celsius temperature. So this is how you will detect 4Hs and treat 4Hs. And 40s, so when you are treating the 40s, always think about tension pneumothorax. So always have a high suspicion. So most of the time during the trauma, isn't it? So if the one chest is not moving, then you have to think whether I'm dealing with the tension pneumothorax, isn't it? So if the tension pneumothorax is an obstructive type of shock, so it won't produce a cardiac output. So they may present with low volume, no absence of pulse if it is not treated. So you have to think about that, and you have to release the tension by putting a needle in the second intercostal space, followed by an IC tube. And volume resuscitation will help you to take some time to deal with the tension pneumothorax, to insert the IC tube. That needs some time, so that you can give some bolus as well as needle thoracocentesis followed by IC tube. So this is how you will approach the tension pneumothorax. So in medical condition, mostly asthmatic patients can present with this, and any choking incidents can present with this. So you have to think in terms of history as well. Cardiac tamponade following surgeries, cardiac condition, trauma, mainly they present like with cardiac tamponade. So this is again, the heart is surrounded by fluid so that it won't let the preload to fill, and cardiac output will be compromised. So what you have to do is you have to release that pressure obstruction by putting a needle in the ciphisternal area, 45 degrees, and aspirate the fluid around the heart, so pericardial effusion. So you have to do that immediately so that the heart will collect the blood and start to pump. So that is the immediate treatment. Here also you can give some volumes to get some time to deal with that permanently. Right, so always refer to the cardiac thoracic people immediately. And toxic substance always have a high suspicion, smell of the patient, that is very important, and pupillary reflection, that is very important. And history, again, you have to think, small children, depending on the age, they may have some substance ingestion, and depending on that, you should be able to treat that patient. And thromboembolic phenomenon, that is very rare in children, but following a long bedridden patient, or cardiac surgery following long surgeries, they can have it. So always think about it and try to identify one of the causes, or 3 or 4 causes. If you can identify these reversible causes very quickly, and if you can able to resuscitate these patients, you can immediately recover the patient from the arrest. So it is very important to reassess whenever you have time. As a team, you should be able to collect information about the patient, and you have to immediately treat the patient. So have the drug doses with you and equipments needed for the resuscitation with you, so that the resuscitation will become more successful in this cardiac arrest. Now we will move on to the rhythm. So when you move on to the rhythm, you will see there are shockable rhythm as well as non-shockable rhythm. Asystole and pulseless electrical activity, that is the most common rhythms in children, cardiac arrest rhythm in children. So those are called non-shockable rhythm. And ventricular fibrillation and pulseless VT, those are very rare. Mostly less than 10% of the children will have this type of rhythm. And this is shockable rhythm. So non-shockable rhythm and shockable rhythm. Now we are going to see what is this rhythm. Any idea, any chat box ideas to shockable, what is this rhythm? So this rhythm is called, everyone is sleeping, asystole, isn't it? So when you confirm this as asystole, when will you confirm this as asystole? When your monitors are connected to the patient, your monitor should function properly. Yes, lead should be attached to the patient. Otherwise, you should not confirm this. Look at the patient, right? That is very important. If they are unconscious, color is pale, then you have to think about whether I am dealing with an asystole. So asystole is the common form of arrest rhythm in children. Common cause is, most important cause is hypoxia. So they can be respiratory failure hypoxia or shock hypoxia. So this is the common pathway for this rhythm. So if you see this rhythm, you have to immediately resuscitate this patient. Okay. So in children, once the arrest occurs, it is very hard to recover them. But if you can immediately give your care, they can come out with the arrest. This is what is this rhythm called? Any idea? Any idea on this rhythm? No idea. So this is PQRS. Yes, one answer, pulseless electrical activity. So when will you call this as a pulseless electrical activity? When will you call this as a sinus rhythm? Isn't it? So that is the question. So pulseless electrical activity means there is electrical activity in the heart, but the heart won't function. So this is called pulseless electrical activity when there is no pulse. Okay. So that is the clear definition for pulseless electrical activity. This is also a very common rhythm. So in the ward setup, usually you can see this. So once you see this rhythm, and if the rhythm is there, but the patient is not moving, patient is having different color, if the condition changes very rapidly, then you have to think about whether I'm dealing with the pulseless electrical activity. So that is how you will detect this type of rhythm. Otherwise, you can miss this rhythm at any point. So always immediately go and check the patient's pulse. So that will tell you whether you are dealing with the arrest pathway. So if you don't treat this, this will lead to tachycardia about 200. Then if you don't treat, that will cause immediately drop the heart rate and they will go into asystole and death. Okay, so this is how the pathway goes. So this is another common type of rhythm, mostly in septic shock. Those patients, blood loss situation, these type of rhythms can come, right? So be careful about this type of rhythm. So once you see this non-shockable rhythm, you have to assess the rhythm. And once you see the non-shockable rhythm, pulseless electrical activity or asystole, you immediately establish your basic life support. So one team will do that. While doing that, the other team will start to cannulate the patient. So once you cannulate the patient, you have to immediately give your adrenaline. So that is very important. So IV access or IO access. So IV access can take 1 or 2 minutes. So if you can't get IV access, what you have to do is you have to immediately go for a IO access. So after getting IV and IO access, you have to collect blood for investigation. So that will help you to find out so many causes. So full blood count, HB will help you. And then electrolytes, potassium, sugar, bedside investigation, VBG, those will help you to identify the underlying problem. So send it to the lab immediately and collect the report immediately. So while this is going on, you are continuing the CPR for 2 minutes. So each cycle takes 2 minutes, right? So if you start the CPR, your CPR cycle should go 2 minutes while doing all these jobs. So if you have time, another person or leader can go through the 4Hs and 4Ts and try to resuscitate these 4Ts and 4Hs. So first cycle, you access the IV and then you give your first adrenaline and continue the cycle for 2 minutes. At the end of the 2 minutes, you will see whether the pulse is returned or not. If there is no pulse, you restart your CPR cycle. And this adrenaline falls every other cycle, 3 to 5 minutes interval. So don't give the adrenaline in the second cycle. You continue the CPR till 2 minutes, stop it and see the pulse. If there is no pulse, you will reassess the patient for 4Hs while continuing the CPR and give your second bolus of IV adrenaline. So every other cycle, you will give the adrenaline to the patient. So adrenaline here is basically playing a role in order it will increase the coronary perfusion and cerebral perfusion by vasoconstricting the peripheral vessels, and it will maintaining a diastolic flow so that the coronaries will get perfused. So that, and there is some contractility effect of adrenaline. So adrenaline is a drug, important drug, but BLS plays major role in surviving, keeping the vital organ function, maintaining the vital organ function. So continue the CPR till 2 minutes. Once the 2 minutes up, you stop it. If the pulse is returned, then what you have to do is you have to move on to the post-resuscitation treatment. So these are the important steps you have to do while you are resuscitating a patient. So we went through all these things. So make sure that oxygen is going on and make sure you are removing the 4Hs and 4Ts. So once the patient recovered, what you have to do is you should not leave the patient. That is very important. You have to give the post-resuscitation care. So post-resuscitation, going through the A, B, C, D, E, and giving all the system stabilization, near normal physiological value you can achieve. And what you have to do is you have to do a 12-lead ECG, and you have to continue to search for 4Hs and 4Ts, and you have to maintain the temperature control. Don't treat the hypothermia aggressively, but you can rewarm the patient little by little and bring the patient towards normothermia. Right. Now we are moving on to shockable rhythm. So any idea on this rhythm? Is it a narrow complex or broad complex? VF, yes, VF. So this is VF rhythm. So this is irregular broad complex, right? So there is no P wave, QRS complexes, but irregular. So this is ventricular tachycardia. So always ask whether I'm dealing with a narrow complex or broad complex, regular or irregular. That will give you an answer about the rhythms. So this is rarely occurs in children, mostly due to electrolyte imbalances. Hypothermia can cause in Browning children. So this is the rhythm you are going to deal with. So once you saw this rhythm or pulseless VT, regular QRS complex, broad QRS complex with no pulse, then you have to defibrillate this patient. So in this patient's heart won't pump out blood effectively. It will have very irregular contraction. So that what you have to do is you have to stop the heart, and then you have to restart the heart by doing defibrillation. So defibrillation will stop the heart, and then when you give the CPR immediately, it will restart the heart. So that is how you will manage. So again, we will go through the algorithm for shockable rhythm. So it takes again 2-minute cycles. So once you detect the rhythm, you immediately connect the monitor here, not IV access. Okay, immediately connect the monitor, because studies have shown that if you give shock immediately, the recovery is very quick, right? Outcome is good. So that you have to connect the monitor, and you have to give 4 joules per kg in any children, any shock. Okay, so you will give your first shock 4 joules per kg, and you will continue the CPR for 2 minutes. Get IV access and search for 4Hs and 4Ts. At the end of the 2 minutes, again reassess. If it is the same, then you will continue the shock for 4 joules per kg and the first dose of adrenaline following the second dose of shock. So that is again 0.1 ml per kg, 1 in 10,000. You give it as IV and with a flush. So immediately continue the CPR while searching for 4Hs and 4Ts. Now, at the end of the 2 minutes, you reassess the rhythm. So once you found there is ventricular fibrillation or pulseless VT, you go for the third shock. While going for the third shock, always seek for help. That is very important. Pediatric cardiology people, there may be underlying causes. They might give you different ideas. Meanwhile, you search for 4Hs and start your amiodarone 5 milligram per kg as a bolus. Okay, so after the third dose, you are giving the amiodarone. Continue the CPR till 2 minutes. At the end of the 2 minutes, what you have to do is you have to check for pulse. And if there is pulse, that tells you return of spontaneous circulation, and you will go for the post-cardiac arrest management as we did in the shockable, non-shockable rhythm. So any questions from this algorithms, both algorithms? Chat box you can provide. type the question if you want any questions. Clear? If any comments? Okay. No questions. Okay. So as there is no question, we will move on to defibrillation. Defibrillation, familiarize your cardiac monitor in your unit. It is very hard to deal with the monitor even for a familiar person if the monitor is new, right? It will take time, but that will harm the patient. So what you have to do is you have to familiarize your own monitor. Always make sure the power is connected to the monitor. And once you see the monitor, you on the monitor, and you have to select 4 joules per kg in any child. Okay, so if the child is 10 kilos, you will select 40 joules, or if there is no 40 joules, maybe 50 joules, you can select it. So that is how you will do. There are pediatric pedals as well as adult pedals. You can see that and you can use it. So over 8 years, you can use the adult AED. AED is automated external defibrillator. Nowadays, 1990 people are bringing. It is automatically detect the rhythm and it delivers its command, and you can follow those commands and you can resuscitate the patient. Right. So over 8 years adult use, under 8 years, you can use the pediatric pedals. Then family presence during the resuscitation. So family presence during the resuscitation. So when you are resuscitating, if the family members want to see the resuscitation process, you can keep them there. But if they are troubling you or if they are not cooperating with you, then what you can do is you can ask them to leave out, and you can appoint a person to tell the problems then and there, because they will be breaking the bad news is very important during the resuscitation process. So that you have to keep them away and you have to tell them. Right. So that is how we treat the family members during the resuscitation. So when you are resuscitating a patient, as I said, airway comes first, and then once you establish your airway, and you will start assess the breathing. So if there is no breathing, what you have to give is 2 rescue breaths. So once you give the 2 rescue breaths, you assess the circulation. So if there is no circulation, you immediately start your cardiac compression. So that goes as 15:2. So 15 compression and 2 rescue breaths. So 2 breaths, this will go alternatively till you achieve till you recover the patient from the arrest. And disability. So finally, you will go and analyze the disability. Any questions from up to now? Chat box, any questions? No questions. Okay. So as there is no questions, so we can end up. So once you detect the cardiac arrest in children, you have to follow the DRS approach, danger, responsibility, and send for help. So after sending that, you have to open up the airway, look, listen, feel. And once you open up the airway by positioning and manual, and then you can put an oropharyngeal airway, or if you need, you can intubate the patient and give 2 rescue breaths. So that is bagging through the self-inflating bag. And after giving 2 breaths, then you have to check for pulse. So if there is no pulse, you will start the CPR 15:2, 100 per minute, 1/3 of the depth you should access. And after that, you access for the rhythm. So assess the rhythm. So it can be shockable or non-shockable. According to the rhythm, you should be able to follow the algorithm. So once the patient recovered from the arrest, what you have to give is post-resuscitation care. Otherwise, patient can go into again the same vicious cycle. Okay, thank you for the lecture. And next, I can stop share. Okay, thank you.
Right. Thank you very much, Dr. Brinda Shivakantan, on that detailed explanation how to do adult pediatric resuscitations. So if there's no questions, so we'll go to the next lecture by Dr. Dejan Adihetty on high flow nasal oxygen therapy. That's the last lecture before lunch. So after we'll break for lunch. Right. So Dr. Deshan Adihedi is a consultant intensivist, pediatric intensivist at LRH. So over to you, sir.
Can you hear me?
Yes, I can hear. Yeah.
You can see the screen also.
No.
Okay. Can you see the screen?
No, sir.
Hello?
Not yet. No, can't see.
I can't see the share screen option. All right. Okay. Okay. Right. In this next half an hour, we'll be discussing on high flow nasal oxygen therapy. So the objectives are to understand what is a high flow nasal cannula system, to understand the mechanisms under the high flow nasal cannula therapy, and to know about the indications and contraindications, and to understand how to select a cannula and what you need to prescribe when you put a patient on high flow nasal cannula therapy, and what to monitor and when to escalate. So this is a high flow nasal cannula system that you can see. Right. So this is the nasal interface. Then you have the humidified system of tubing, and this is the high flow machine, and this is the humidifier electrical system. Then this is the sterile water for the humidifier, and the flow rate is 2 liters per kg per minute. That is prescription. So you can provide from 2 liters to 60 liters per minute from this machine. So the features of a high flow nasal oxygen system is mainly 3, right? So it is an open delivery system. It provides optimal humidity with temperature, and it provides gases with high velocity. Why I said it's an open system is when you attach the nasal interface, it should not cover the entire nasal diameter. Only 50% of the nasal diameter should be covered by the nasal interface. and the mouth may be open or closed, right? So that's why it's called an open system. So it provides optimal humidity and temperature. So there is a humidifier. The gas which is coming through the machine is passing through the humidifier, where it collects the water vapor, and then it is sent through the patient's interface through the tubing system, and it's heated and humidified. So this humidification is a very important thing, because usually medical gases don't contain any water vapor. So if you give gas which dry gases, your mucosa will dry out, and your mucociliary escalatory mechanism will be impaired, leading to airway obstruction, atelectasis, and so on. Therefore, when you provide humidified gas, the mucociliary function will be not limited, right? So the mucus will be secreted at normal and not dried off, so that there is less airway obstructions. So the evolution of high flow nasal system comes from this story, which was published in New England Journal of Medicine in 1993. Yeah, a lady with acute left ventricular failure was rushed to the hospital by her husband, and she noticed that whenever she was facing the forward airflow, it was easy for her to breathe, and whenever the husband dropped the speed, there was worsening of difficulty of breathing, right? So this led to further evaluation and then development of this high flow nasal cannula system. So what happens when you attach a high flow nasal cannula to a patient? So this is the pharyngeal pressure in water centimeters on the y-axis, and the gas flow in liters per kg per minute on the x-axis. When you plot the pharyngeal pressures, you can see as you go on increasing your gas flow, the pharyngeal pressures increase, right? So what people notice is this is the end expiratory pressure in the pharynx, and this is the flow rate per kg per minute, right? Liters per kg per minute. So now, when you increase the flow rate, there is an increase in the end expiratory pressure in the pharynx. You can see that most of these are scattering around this area, right? Somewhere between 2 to 3 liters per kg per minute, right? So this led to the finding that children or adults, whatever, they should be prescribed, the flow rate should be prescribed as 2 liters per kg per minute. I repeat that, 2 liters per kg per minute, right? So that is a standard flow rate. So then this is a graph which describes the airway pressure in relation to the inspiration and expiration. So in a normal patient who is not on high flow therapy, the inspiration, as you contract your diaphragm and inspiratory muscles, you increase your intrathoracic volume and drop the pressure. So the airway pressure becomes negative, right? And the expiration is positive. But when you attach a patient to a high flow nasal cannula system, this inspiratory part also becomes there's a positive pressure in the development of positive pressure in the pharynx, like a PEEP, right? So what is the reason for reduction of work of breathing? As you may see, when you put patients on high flow therapy, their work of breathing will reduce, right? Their respiratory rate and work of breathing will come down slowly. So this is what is the mechanism? So on your y-axis is on the left upper corner, y-axis is the pharyngeal pressure, and your x-axis is the time. So on the left hand side is without high flow nasal cannula therapy. On the right hand side is with high flow nasal cannula therapy. So the main thing you notice is the pharyngeal pressure. Here in inspiration it's negative, expiration is positive. Whereas with high flow nasal cannula therapy, throughout the respiratory cycle it maintains a positive airway pressure. And look at the this is the piece S is the esophageal pressure with thigh. So without high flow therapy in a child with pneumonia, so you can see that with inspiration, you have to create a negative pressure of minus 40 centimeters water to overcome the compliance and resistance work of the lung, right? So people want to quantify this value of energy. So they developed a concept called the pressure time product, which is the drop of pressure during inspiration times the duration that pressure is going to be applied, right? So that is the pressure time product, which is colored here, right? So when you compare this pressure time product on a patient who is without high flow therapy and with high flow therapy, you can see the pressure time product has reduced with high flow therapy. The amount of work needed to be done has reduced. The amount of negative pressure that needed to be generated has reduced because of the positive pressure effect on the pharynx. So that is the reason as to how the work of breathing is reduced. So what are the gas flow dynamics during high flow nasal oxygen therapy? So as you can see, when you attach the nasal interface, gas is flowing at high velocity. It entirely fills your part of your anatomical dead space, right? So this is not directly involved in gas exchange. Usually this space is filled with exhaled gas, which is rich in carbon dioxide. So when a normal patient, a patient who is not on high flow therapy exhales, the anatomical dead space is filled with carbon dioxide rich gas. So with the next inspiration, invariably the part of the inspired gas will accommodate this dead space carbon dioxide. But when you attach to high flow therapy, what happens is the dead space is washed out with oxygen rich humidified gas. So with the next inspiration, instead of taking up of carbon dioxide rich gas, you take oxygen rich gas. At the same time, you are washing out your carbon dioxide. That is how it helps to increase your oxygenation and removal of carbon dioxide. So what are the other impacts of high flow nasal oxygen therapy? So as I explained, it decreases the work of breathing by maintaining a positive pressure and reducing the nasopharyngeal resistance. It ushers the anatomical dead space. It provides some amount of PEEP, somewhere between 5, 4, that range. So because at the same time it reduces the energy expenditure by reducing the work of breathing. Because of humidification, it improves the mucociliary function and secretion drainage. So because of high flow therapy, the intubation rates has drastically reduced in ICUs nowadays. And therefore, complications of mechanical ventilation and sedatives, analgesics has come to a lesser extent. So let's look at the indication. So any respiratory condition is an indication. Bronchiolitis, pneumonias, asthmas, cardiac conditions, which is affecting the lung, heart failure. Then for de-escalation, for escalation as well as de-escalation. De-escalation, post-extubation care. Then after cardiac surgeries, or even during the process of intubation as a means of oxygenation, you can use the high flow nasal cannula. Contraindications wise, so if you don't have a patent upper airway, you can't use this. So that's why coronary artery says. If your airway protective reflexes are impaired due to central nervous system issues, then it's unsafe to use high flow nasal cannula therapy. Right? If the patient is having a reduced respiratory drive with apnea, you can't use high flow nasal cannula therapy. It will not help. Or impending respiratory arrest due to hypoxemia or hypercapnia, again you cannot use this because it's not going to help at that stage. It's too late. Right? Or trauma to the basal skull or the maxillofacial traumas where your anatomy is disturbed again. Right? You cannot use. Foreign body aspirations and pulmonary aortic syndrome. So what are pulmonary aortic syndromes? Basically, pneumothorax, pneumomediastinum, subcutaneous emphysema, and pneumopericardium. So those are the those are the pulmonary aortic syndromes. Right? So what should you prescribe? The amount of FiO2, the flow rate, as I mentioned, 2 liters per kg per minute, which is a static for all. Temperature, 37 degrees Celsius. And the mode, whether it's pediatric mode or adult mode. FiO2 prescription will depend on your disease condition. When you have a left to right chance, you are trying to manage with a lower FiO2. Otherwise, you will increase the pulmonary blood flow. Right? If you are put in a child with persistent pulmonary hypertension, you go on with PPHN on high flow nasal therapy, then you have to use 100% oxygen. Right? How to select the cannula? So you have to come. So there are various sizes of cannulas from extra small, small, medium, large, and extra large. So you have to compare the diameter of this nasal interface with the patient's nares, keeping in mind that whatever you choose should only obstruct 50% of the nares, not 100%. So depending on that, you choose the nasal interface. Then flow rate is 2 liters per kg per minute. So different nasal cannula systems can have different flow rates. For example, the extra small cannula system can deliver a flow rate from 0.5 liters per minute to 8 liters per minute. A small one will deliver from half liters to 9 liters. A large one will deliver from half liters to 23 liters. An extra large will deliver from half to 25 liters. Right? So then you should calculate. So you selected the nasal interface and then you should calculate the flow rate. Say, assume the patient is 5 kilos. You had the flow rate should be 10 liters per minute. Then there are two options. Sorry, there is only one option here or here, right? So then you have to select from these what is going to close only 50% of the nasal diameter, right? So that's how you select. So what should you monitor? All basic parameters: the respiratory rate, the respiratory pattern, and the work of breathing, oxygen requirement and oxygen saturation, and the heart rate should be monitored. So if you can do a blood gas before high flow therapy and after 2 hours of high flow therapy, then you can come see whether the patient's dynamics are improving or not. Right. So studies have been done and they have seen that the heart rate will improve by 10 minutes, respiratory rate by 15 minutes, oxygenation by 15 minutes, work of breathing by 30 minutes, right? So these are only studies. Now don't go and remember these, that this should settle by this time. It depends on the patient's disease condition as well. Right? So when should you escalate? If the patient is not stabilized by 2 to 4 hours or the blood gases are worsening, the work of breathing is not improving, instead it's worsening, oxygen requirement is increasing, then you have to think of escalation. So the next thing is to intubate and ventilate or go for non-invasive face mask, right? So in these patients, it's important to do a blood gas and a chest X-ray. So always learn to observe the patterns of the chart. Now, you can see we have started high flow therapy here, right? In this patient, there is no response. But in this patient, it's responding, right? Here, the heart rate versus time. So if the hypoxia is settling, the heart rate also can come down slowly with the respiratory rate, right? So you can see the pattern. Then once you start high flow therapy, then you have to treat the underlying cause properly and allow adequate time for this underlying pathology to settle. Right? Then only you can think of weaning. Say you put a patient on high flow therapy, the workup breathing came down by 2 hours. That is not an indication to wean the patient from high flow therapy, right? So treat the underlying cause, give adequate time for that to settle, and then think of weaning. Weaning begins with weaning of the FiO2, right? So we can slowly come down up to 30%, and then you can remove the high flow nasal cannula system and connect to a nasal probe or put the patient on room air. We do not wean the flow. There is no means to wean the flow, right? Nursing care. So you have to check the nasal interface at least hourly, because that is a place where secretions can obstruct the interface. And sometimes we have seen patients going into obstructive breathing pattern simply because the secretions were obstructing the nares and the high flow cannula system. And people have tried to intubate this children also, right? Because of that breathing pattern. So simple thing to do is just to do the suction the nose and have a look at the nasal interface when you are doing that. If it's blocked, you have to suck out and clean it. That's all. So other thing is, remember when you're putting a child on high flow nasal therapy, you have to decompress the stomach with a nasogastric tube. Otherwise, gas can be swallowed and it will fill the stomach and it will put pressure on the diaphragm, which is already under stress, and worsen your respiratory mechanics. And to change the site of the saturation probe as well. Can I feed on high flow therapy is another common question. Yes, you can once the acute situation has settled and the patient is on an improving trend, you can start nasogastric feeding or even orogastric feeding, or sometimes even breastfeeding. Next is, can I nebulize on high flow nasal cannulas? Yes, you can, but then you have to use a separate interface for, this is the normal humidifier. When you are using a nebulizer, when you want to nebulize, you have to use a humidifier that has a connection for the nebulizer canister and the power source. This is the nebulization canister and this is the power source, right? And you have to prepare nebulization solutions and put into this and connect to the power source, and then this will be nebulized. Very effective nebulization. We do this at LRH MIC. This is for nebulization. So this is a nebulization canister, and this is the power source, and it is attached to the modified humidifier. So what's new about high flow nasal oxygen therapy with the COVID pandemic? Sorry. Lot of people were put on high flow therapy, then people did research because this is a aerosol generating equipment. So you know that the virus can be transmitted through aerosol. So this is what has happened. So a child without a simple surgical mask is generating lots of aerosols to the environment. But by applying a simple surgical mask, you have reduced the aerosol dispersion onto the environment. Therefore, when you are using high flow nasal therapy on COVID positive patients, it's important to put a simple surgical mask like this on top of the nasal interface. Right? So this will safeguard your staff from attracting the virus. So that's a new thing about high flow nasal oxygen therapy. So coming to the end, take home messages. High flow nasal cannula system is a device that delivers oxygen at high flow rates with humidification. It is used in escalation as well as weaning or de-escalation. It is a bridge between standard oxygen therapy and mechanical ventilation. So you can go this way or go this way and come back to high flow therapy. Right. So going through high flow therapy has reduced complications which had occurred due to mechanical ventilation. So don't hesitate to start high flow nasal oxygen therapy on sick patients who are having increased work of breathing. And don't forget to put the simple face mask when managing COVID positive patients on high flow nasal cannula systems. Okay. Reduce your aerosol dispersion. Okay, that comes to the end of the lecture. If you have any questions, you can ask. So what happens is now someone had asked a question as with regard to nasal irritation. For a normal patient, yes, it might irritate. Some children don't tolerate this, but when the patient has increased work of breathing and you apply the high flow nasal cannula system, they feel the ease of breathing. So then usually what happens, they adapt to this high flow system. So as the initial person described in 1993, the sick patients tend to tolerate this type of flow. Okay, that comes to the end of the lecture. Thank you.
Thank you very much, sir, on the lecture on high flow nasal oxygen therapy. So we'll break for lunch for 15 minutes. So we start at 1:30 sharp. Right. Thank you. Welcome back to second half of the lecture series. I correlate invite Professor Priyanth Pereira, Professor in Pediatrics in Lanka Medical Faculty, on the lecture on basic life support. Over to you, sir.
Sorry, can you hear me?
Yes, I can hear.
Yeah. Just a small correction. I am actually attached to the Lanka Medical Faculty. On temporary basis, I am working at Lanka on sabbatical leave for the helping the Lanka student there. That time my permanent position is at Lanka.
Yes, that's what I thought.
So we are just to discuss about basic life support today. And it's a very important area to learn and something that we should know, everybody should know, right? So we'll just go through. So during this lecture, we learn how to identify a patient in cardiac arrest, and then to identify the practical approach to basic life support, and then to learn about the basic skills you need to provide basic life support, right? So why we should learn about basic life, just for story. The good old story you heard about two friends going in a jungle road, come across a bear coming towards them, and then one friend go and climb a tree. Then other friend has nothing to do. He remembers that bear doesn't eat dead people, so he lies down and pretending to be dead. And then the other friend who is in the climbing the tree hears some noises from downstairs, and he peeps through the branches of the tree and find that for his amazement, the bear is giving basic life support to the patient, the weak friend, because he doesn't want to eat the dead person. And then this friend is ticklish, and then he starts to wriggle around, and then bear is happy that he has resuscitated the patient, and then says something to the friend and goes away. And then after a while, the friend who was in the tree comes down and asks, hey mate, what did that bear tell you? And then he said not to go with somebody who does not even know basic life support hereafter. Right? So nowadays, even bears know how to do basic life support. So even basic people, lay people know about basic life support. And being doctors, it's a shame if you don't know about basic life support, right? So you should learn this skill, and you should not be scared or afraid to employ this when it matters, because it saves lives. So if you don't believe in basic life support, take my word, it saves lives, right? Basic life support saves lives. So you can save lives if you learn this technique properly. So learn this and practice it, because one thing is you can learn this from a lecture. You're practicing on mannequins, and then actually real practice and real patients when you get an opportunity when you're working in the wards, right? So this is skill that you learn by practicing, but before practicing, you should know, have a sound knowledge, clear knowledge about how to do it in a real setting, right? So why we call it basic life support? Because it can be done anywhere, even in the jungle, even in an airplane, even in a ship, right? Anywhere in the world, you can do it. So you don't need to be in a hospital. First thing. Second thing, you don't need any equipments. You don't really need your hands and mouth and brain to use. No need of any equipments and no need of any medication, right? So you can provide it anywhere, and it does not need to be a doctor even, right? As I told earlier, even a lay person can provide basic life support, provided that person had some amount of training about basic life support. Because sometimes if you are not knowing anything about basic life support, your intervention might even be harmful to a victim, right? So any person not needing MBBS to provide basic life support, but should have some amount of training about the skills involved in basic life support, right? If you have any questions, you can shoot in at any time, right? I don't mind. If you have any questions, or if not anything clear to you, or if I'm going too fast, you can always interrupt and tell me, right? So first of all, we should know how to diagnose a patient in cardiac arrest, right? So you might walk into a room and find somebody lying unresponsive, doesn't not be interested in environment, not respond to the environment. So somebody like that may be in deep sleep, He may be just sleeping after a good night booze, right? He may be unconscious, he may be in coma, he may be in cardiac arrest, or he may be simply dead, right? So before you start giving CPR, you have to make sure that the patient is in a cardiac arrest, because if you go and start doing, say, chest compressions or mouth-to-mouth breathing, so somebody is sleeping, he might wake up and then it will be very of a hilarious situation for you, right? So first of all, you should know how to know whether somebody is actually sleeping or in a cardiac arrest or in dead, right? Dead position. So what is the difference between death and cardiac arrest? Anybody can tell me? Yeah, I've already given it here, right? So there are death and cardiac arrest. Difference is that cardiac arrest is where a person has stopped breathing and stopped having his heart beating about a couple of minutes ago, just about few minutes ago, or immediately before this, right? And that means the cells are still living, right? So when somebody's heart and respiration ceases to function, there is oxygen supply and glucose supply to tissues will be interrupted, and there will be cellular death. But for a given period of time, small period of time, it will vary depending on individuals. The cells and tissues can survive for a while, even when the heart and respiration is cease to function transiently. So if you recover the patient's heart and respiration within that period, then you can revive the patient, right? So cardiac arrest means the heart and respiration are stopped for a brief period, right? And you might be able to pick up the heart and respiration, but there may or may not be organ damage, because if there has been a significant delay in initiating the CPR, some organs might have suffered damage, like some areas of the brain, kidneys, some myocardium can get damaged, right? But you may resuscitate the patient, see, right? But dead means there has been cessation of respiration and heart for a longer period of time, that you can't revive the patient again, right? So the cells have died. So it's due to the lack of oxygen and glucose supply, the cells have died. So even if you start the heart and brain, patient will not recover, right? So that's important, because I have seen sometimes even is Shamila, you want to ask something? Shamila, you raised your hands. Okay, I think mistake, right? So if the patients, I have seen sometimes when patients are brought to the OPD, they are actually dead, right? And even sometimes they still resuscitate, right? If somebody is having very low body temperature and having rigor-mortis, that means he is already dead, right? So you can't resuscitate a patient who is dead. So remember that, no point resuscitating dead person, right? It's an important difference between death and cardiac arrest. So if the obvious signs of death, like fixed dilated pupils and rigor mortis, body temperature is almost in the environmental temperature, then it's hardly, and no reflexes, no spinal reflexes are there, brain stem reflexes are absent. In that situation, actually it's a waste of time to resuscitate the patient, because you can't revive that patient. But sometimes we do it actually for the audience, to the parents and relatives, to know that you have done everything, right? So otherwise they'll think you didn't do anything, and they even burn away hospital down, right? So apart from for the audience, there's no point resuscitating somebody has been dead, right? So that is what you have to learn. So how do you identify that somebody is in a cardiac arrest, right? So when you find somebody who is unresponsive, say you enter a room and find somebody lying on the ground, and you think he may be in a cardiac arrest, or he may be dead or unconscious. So how do you know whether he is unconscious or dead or living? First important thing is that you have to scan the area, that have you have to look around the surrounding and look for any dangers, right? So because there may be a snake, the victim might have been bitten by a snake, and the snake might be around the patient, and if you go and start resuscitating, he might bite you also, and you'll be a second victim. Patient may be electrocuted. If you can touch the patient, you might get electrocuted as well, right? So it's important that you look for dangers because we don't want you to be another victim, right? So most important principle is that resuscitator should not be another victim of the situation, right? And again, if the patient is having in danger, unless you remove the danger, patient might not respond to your resuscitation, right? So two-way process. So if suppose somebody is supposed to be electrocuted, first thing to do is to switch off the main lines before even do anything else, right? So similarly, you have to make sure that there is no danger, free from danger. And if there is any ongoing danger to the patient, you remove the patient from the area or you remove the danger from that area, right? And then you check whether the patient is responsive, right? After you evaluate the safety. So what you do is actually you have to check whether he will respond to your commands. And before doing this, you have to again think about the circumstances. If there's any violence, say there's evidence of a fight or a struggle, or there been evidence of accident, fall from height, or in road traffic accident situation, right? In that situation, there is a serious possibility of damage in the cervical spine, right? Sometimes there can be cervical spinal injury without spinal cord being still not involved, right? Spinal cord is intact, but there is spinal cord the spinal vertebra has been damaged. And if you move the patient without taking precautions, that can lead to spinal cord damage, and the patient will have permanent neurological damage or die if the cervical spine injury is higher up in the spinal cord, right? So that you will not move the patient without stabilizing the head, right? So what you do is, if there's no risk of cervical spine injury, you hold the patient with the shoulder and then shake vigorously and shout loud and clearly, "Are you all right?" Right? But if you have a cervical spine injury, if you do that, then that will shake the head, then that will cause cervical spinal injury. So but in doing this, in sometimes they might not respond because they don't know English, right? So they might close it further tightly. Somebody speaking to them English. So you might try to speak in Sinhala or Tamil or whatever language that we use in that area, right? So "Are you all right?" is in English books. So you don't have to do the same thing. You can use your own phrase, right? And if you know the name, best thing is to call him by the name, because anybody is responds best to her name, his or her name, right? So what I do is to shake the patient vigorously and ask, "Are you all right?" So if she's been sleeping, you might wake up and ask, "Yes, I am sleeping. What's wrong?" Then you can say, "Okay," then you can just move away from that place, right? But if he's not responding, then we have to check whether he is in deep coma, deep unconsciousness, or in a cardiac arrest, right? But if there is a cervical spine injury possibility, then we don't shake. We just touch the patient and speak loudly and ask whether the patient is all right, right? And then if he is not responding, then we want to know whether the patient is having a cardiac arrest or not, right? So first of all, in a patient who is unconscious or deep coma or deep sleep, sometimes the airway can get obstructed. So the patient may not be breathing because of the upper airway obstruction. So we have to make sure that airway is opened up, right? So we have to apply airway opening measures. So first thing is check the responsiveness, followed by opening the airway manual, right? So that depends on the age of the patient, the amount of the nature of airway opening depends on the age of the patient. If the patient is under 1 year, infants, then we use what we call the neutral position. We keep the head in the neutral position. I'll tell them about in a second. In older children, we use the position called sniffling of morning air position, right? Like that, right? Okay. So we do this by the manual called head tilt and chin lift, right? But you should not move the head or neck in a patient who is supposed to have a spinal cord injury. In those patients, we don't apply chin lift or head tilt. Instead, we apply something called jaw thrust, right? I'll come to that later in the next slide, right? So the idea is to clear the airway by positioning the head in the correct position. So neutral position in a child under 1 year. Sniffing of morning air position in a child who is above 1 year. Right. So this is what we call neutral position. So you can push the chin up like that and tilt the head from there, holding the hair at the anterior hairline, and then keep the face parallel to the surface of the patient lying. So if the patient lying on a floor, the face, the plane of the face should be parallel to the floor. You should not hyperextend, you should not flex. Both hyperextension and flexion will close the airway in an infant, especially in a newborn babies, neonates, right? So though we do the hyperextension in older patients, we don't do that in infants. That will close the airway, right? So that is the position we use for a infant. And in older child, as we told here earlier, we use the chin lift and head tilt. You lift the chin with 2 fingers like that. You keep your other hand at the anterior hairline and tilt the head. So use both hands because the older patient will be more heavier, right? So you push up the chin up like that. You can see that with that you will move the neck, right? So if there's cervical spine injury, this will damage the cervical spine, right? So you should not do this if there's cervical spine injury is there. So we can the figure illustrate what happens. Here you can see in the unconscious patient, tongue has fallen backwards and blocked the airway. You can see the airway is blocked here, right? When you apply this maneuver, you can see the tongue is pushed up like that, and the airway becomes clear, right? This is what we achieve by doing this maneuver, right? Head tilt, chin lift to make the upper airway patent, right? Okay. Any questions up to now? Anything you want to ask up to now, you can ask. Anything unclear about up to now? Any questions? Right. Okay, we'll move on. You can ask them at the end of the lecture if you want. And then we can use this. If the patient is having a suspected cervical spine injury, we use what we call jaw thrust. Here you stabilize the upper part of the head. The vault of the skull is stabilized with thumbs, and with other fingers you push the jaw forward like that. So without moving the upper part of the head, skull, you move only the jaw forward, right? By doing that, you push the tongue forward and open up the airway. So here you are not moving the head in relation to the spine, right? There is no spinal movement, so there is no risk of damaging the cervical spine, right? So this is what we apply when you're having a suspected cervical spine injury, the jaw thrust, right? The jaw is only moved without the vault of the skull, right? And once you open up the airway, and now we want to check whether the patient is breathing, right? So you open up the airway, you can see the patient in the figure. The patient is being lying down, and somebody is applying chin lift and head tilt, and now listening and feeling and looking for breathing. Something wrong in this figure is that this victim's shirt should have been removed because you can't see chest movements otherwise, right? So what you do is you keep your ears over the patient's nose, you keep your cheek over the patient's mouth, and then you look down at the chest. So you listen for the breath sounds, you feel for the expiratory air, and you look down on the chest wall to see whether the chest is moving up and down, right? So you do this for 10 seconds, not forever. And then if there is no evidence of breathing by looking, listening, and feeling, then you come to the conclusion that patient is having a respiratory arrest. Then you move on by giving mouth to mouth or mouth to mouth breathing, right? Now, what is mouth to mouth breathing? You are giving exhaled air to the patient to resuscitate the patient. Now, in a situation like this, in COVID pandemic, it is not safe to give mouth to mouth breathing to a patient, right? Even in other times, whether you are going to give mouth to mouth breathing to a patient is up to your conscience, because there is a potential risk of transmission of infections through the mouth to mouth breathing. right? It's up to you to decide on your conscious. So what I do actually is, while maintaining the airway, always airway should be maintained. You should not release the airway. While maintaining the airway, what you do is you take a deep breath and then exhale, and then most of the upper airways will be cleared of air. And then you take a deep breath so that fresh air will be in your lungs and upper airways. And then you pinch the nose, right? Pinch the nose and then cover the mouth with your mouth and blow slowly and forcefully down the patient, right? So if you don't pinch the nose, air will escape to the nose. You want the air to go to the lungs, right? So that's how you pinch the nose. And then should not be exhaled in a one go, like, right, like blowing a candle, right? Because that's not the way we breathe. So it should be a slow and forceful expiration to send your expiratory air into the patient. That's the goal of mouth-to-mouth breathing. But in a child who is having small, but 1 year, under 1 year, you don't have to do that, because you can cover the both nose and mouth with your mouth, right? Like this. So you don't have to pinch the nose. You cover both nose and the mouth together, and then blow into the mouth and nose both together, right? So that's what I do in a small child, where you can cover the both nose and the mouth with the mouth, right? And then the issue of mouth-to-mouth breathing can be eliminated by this, what we call this mouth-to-mask breathing. There are specially devised masks, right? With a one-way valve and a protective valve here, which will protect you from viruses and other transmissible diseases. So it will allow air to go to the patient, but expiratory air will go out from the vents down there, above the below the valve. So right, so it's what we call mouth-to-mask breathing. Very handy thing to carry in a pocket, the pocket mask, or in a glove compartment of your car, so that you can resuscitate somebody without having risk of getting infected, right? An important thing is this device was invented by a Sri Lankan doctor called Dr. Tony Don Michael, who's a neurosurgeon, I think. Is now in USA, but he was graduated from Sri Lankan Colombo Medical Faculty, right? So it's a pride for us actually, but unfortunately it's not available freely in Sri Lanka. As usual, the common and important things are not available in this country. We have all the junk that is not important, but things like this is not available freely in Sri Lanka, right? But this is a handy thing. If you can get hold of thing, have it in your pocket or in your close vicinity, so you can use it without having the risk of getting infected from a patient, right? So it's called mouth-to-mask breathing. So what you do is you give 2 breaths, adequate breaths, and you can try up to 5 breaths. So you can go up to 5 breaths, and once you get 2 good breaths, that means when the chest rises with the expiration, then you know the air has gone to the patient. So if you get, once you get 2 good chest rises, you can stop the breathing, right? So 2 good chest breathing, right? And then you go for the heart. You have checked the air responsiveness, you check the air, open the airway, you give 2 breaths. Now you check whether the patient's heart is working, right? This is slightly different in adults. Remember, in pediatrics, we start with the airway breathing circulation, right? Because most of the cardiac arrest originate from a respiratory problem like asthma, pneumonia, bronchiolitis, right? Commonly the cardiac arrest in children are primarily respiratory. The cardiac arrest is secondary event. Whereas in adults, most of the time the sudden cardiac arrest are due to cardiac problems like myocardial infarctions or arrhythmia following myocardial infarctions, right? So most of them are cardiac origin. So they start with the chest compression, the thump, the precordial thump and the chest compressions. So the ABC approach is not followed in adults. But in children, we go for airway breathing, then circulation, right? So we take the pulse. In older children, we go for the carotid pulse, right? Where you can feel it in the upper part, apex of the anterior triangle. Here you can feel it, right? It's easily felt. You are pressing the carotid artery over the cervical vertebral the transverse processes, right? So you can feel the carotid pulse there in the anterior part of the neck, right? That's the apex of the anterior triangle. But in children, they have very small children, infants especially, they have a short neck and their neck is having a lot of fat, right? So it's difficult to feel carotid pulse in a small child. So in small children under 1 year, we generally recommend to go for the brachial pulses on the brachial pulse or the femoral pulse, which is easily felt in infants, right? So whichever the position, you check it for 10 seconds. You count it 1, 2, 3, 4, 5 like that for 10 seconds. If you can't feel the pulse, then you ascertain that there is cardiac arrest as well. So there is no breathing and no heart. So that is cardiorespiratory arrest. Now we have to start chest compressions, right? So now only we go for chest compressions in pediatric practice. Okay, not that. So don't start just chest compressions in a new child. First thing is airway, then breathing and chest compressions, right? So the chest compressions, what you are trying to do by giving chest compressions is mimic the systole and diastole. You are pressing the precordium like that, and with that you press the myocardium, the ventricles, and blood will go out from the left and right ventricles, right? From the right ventricle it will go to the pulmonary circulation, from left ventricle it will go to the heart and the brain. So we are mainly concerning about the coronary circulation and the cerebral circulation during resuscitation, not the other ones, right? So it's not a big distance, and mainly the coronary circulation, right, in children. So you have to press it firmly down. So you are actually mimicking the chest heart contraction, right? No point doing just small massaging. Should be compressions, right? So press down. You have to press about 1/3 to half the width of the chest wall to mimic the systole, and then you take your hands out, you mimic diastole, right? So there will be filling of the ventricles with blood. So remember, both systole and diastole are important. Some people just go on compressing like that, not without allowing time for diastole. That won't going to work, right? Because heart ventricles should get filled up for blood to go out of the ventricles, right? So when you press down, you get the systole-like thing. Blood go out of the ventricles. When you release, it's mimic diastole. The ventricles get filled with blood, right? So it's very important the sequence is maintained. So what we do is usually count. We count 1 and 2 and 3 and 4 and. So the number will indicate pressing and indicate releasing. So you will periodically get the systole and diastole so that both function will be maintained adequately, right? So one major objective is to send oxygen containing blood to the myocardium, right? Because when the heart has stopped to beat, when the heart is not beating, the best way to get it to beat again is providing oxygen to the myocardium, right? That you can achieve by sending blood to the myocardium, but for that, there should be oxygenation taking place. That's why we should get the airway and breathing established before giving the chest compressions. So if there is no oxygen in the lungs, even if you send blood to the lungs to the right ventricle, there won't be any oxygenation, right? So for oxygenation to take place, lungs should be getting air from the environment or some from your resuscitation or some process, right? So without that, sending blood to the lungs is not going to work. That's why we go through the ABC scenario, right? And then the correct technique should be employed because you have to mimic systole and diastole, and the technique depends on the age again, right? How old the patient and how big the patient is. In newborn babies, right, we use what we call the encircling method, right? Encircling method where you encircle the patient with your fingers and thumbs. So you bring thumbs in front and fingers behind, like that, right? So the patient is front is that side. So you bring your thumbs in front, fingers from behind, and then you press with your thumb down, like that. Force of thumb. So location is just below the nipple line, just below nipple. You encircle the chest wall and press. But 1/3 of the chest wall should be compressed in a newborn baby, like that, right? Suppose the patient is bigger, larger, and your fingers are short, or you are the only person doing the resuscitation. There's no two people. Then you can use what you call the 2-finger method, right? You apply 2 fingers, again same location over the sternum, just below the nipple line, and you press like that. You press for 1/3 of the chest wall should be depressed down, right? So that is what you do in infants and neonates. In an adult, you use what you call the both hand method. Yeah, you have to apply pressure, right, with the ball of your palm over the sternum, right? Don't give it over the rib cage, right? It should be over the sternum, right? Interlock your fingers like that, right? Lean over the patient like that. You can see here, you lean over the patient, and your elbow, wrist, and the shoulder should be in the same line, vertical line, right? The elbow, the shoulder, elbow, and the wrist should be in the same vertical line. You lean over the patient, right, at right angles, so that you can use your body weight to compress the patient's chest. You would have to use a muscle power for this because it takes long time. You might do it for about 20 minutes. And if you use a muscles for this, you will get easily tired, right? To prevent that, you use your body weight. So when applying the pressure, you just push down your weight on the patient, and then you release your hand. The elastic recoil will bring back the chest wall to the original position. So diastole will take place spontaneously. Systole by applying the body weight on the patient. So if it's a child is a big one or an adult, you use both fingers. Fingers interlock like that, right? But if it's a small child, this might be too forceful. You can use one hand like this one, right? Whatever method you use to make sure that you lean over the patient. So if the patient is on a bed where you are too short to get access to the patient's chest without bending your elbows, then you get down to the bed, right? Whatever method to make sure that you got your straight hand over the patient at right angles, right? So what you do is you give 15 chest compressions and 2 breaths. In adults and older children, you give 15 chest compressions and then give 2 breaths, right? And when you're giving the breaths, you have to make sure that you are not doing chest compressions, because if you press the chest wall while somebody is giving the air from pressing the chest wall, right? When the chest compressions are, when the breathing is given, you should release the chest wall. Don't do it both together, right? And in a neonate and infants, about 1/3 of the chest wall need to be compressed. In older children, but half the chest wall should be compressed. And breathing should be continued while the respiration is, chest compression. Sometimes people forget to do respiration, they go on continuing with the chest compressions. Then it won't work, right? So make sure that respiration continues. So after each 15 chest compressions, you give 2 breaths. But in infants and neonates, we give 3 chest compressions and 1 breath, right? For each 3 chest compressions, 1 and 2 and 3 and a breath. 1 and 2 and 3 and a breath. For older child, 15 chest compression and a breath, right? Then 2 breaths. That's because in children, the primary cause is in most younger the patient, the breathing becomes more important than chest compressions. As the child gets older, chest compressions become more important. But anyway, this is the rhythm that you have to apply. 1 to 3 in infants, 15 to 2 in older children, right? Then once you give this for 30 seconds, right? That means 15 chest compressions. It will take about 30 seconds for give 15 chest compressions, right? So you give 2 cycles of that, 15 chest compression and 15 chest compression. But 30 chest compressions will take about 1 minute. That should be the targeted rate of chest compressions, right? But 15 chest compressions for 30 seconds, right? The breathing is intermittently. And then after 1 minute of basic life support, in resuscitation like this, you call for help, right? Unlike those days, you don't have to go for finding a telephone line, because nowadays mobile phones are there with everybody. You can just dial the ambulance services and inform them your location, and other brings an ambulance to your location, right? So you stop the resuscitation for a brief period and call ambulances to send a team to pick up the patient, and then again you restart chest compressions immediately. Don't waste time, right? You only stop the basic life support to call the ambulance services, and would immediately restart, and you continue chest compressions and breathing until the ambulance arrive at the scene to take the patient, right? And after about each minute, you can recheck with the patient has recovered or not, right? And if you manage successfully resuscitate the patient, is supposing you get the heart back, get the breathing back, right? Don't leave the patient and go, because there can be secondary arrest or there can be complication due to arrest. So if patient recovers, keep the patient in recovery position like that, head low and in this position, because due to resuscitation, they might vomit due to asphyxia, and then because you have been compressing the epigastrial region also, there can be vomiters. And if they aspirate vomiting again, all your efforts is going to be useless, right? So keep the patient in left lateral position like that, in recovery position, and then wait and observe the patient until ambulance services return. So the same applies when in hospital setup. Only thing is that you will have your equipments and you will have your ambu bags and things ready for that. So if we go through the scenario again, so what we are doing is we find a patient who is unresponsive, right? And then we check whether patient really responsive or not by doing the "Are you all right" maneuver. We shake them and then check whether they'll respond. If they don't respond, we shout for help. Right? Earlier days, we were told to shout if somebody is found unconscious on the ground. But here we is sleeping, right? So we don't want to get the entire crowd around the patient who is sleeping. So we check if the patient is unresponsiveness, and then if they're not responding, you shout for help, somebody, because this somebody else possible cardiac arrest is there, because more people around better, because you need more than one person to resuscitate, right? So shout for help and then open the airway, right? Because the airway is blocked, the patient can't breathe, and then check whether the patient is breathing. If patient not breathing, you can give 5 rescue beds, but if you get 2 good chest risers, that you can stop after 2 good chest risers, and then check the pulse. If pulse is not there, then give 15 chest compressions and 2 breaths. Go on for about 2 cycles like that. Check the responsiveness. If patient remains in cardiac arrest, call the emergency services to send an ambulance. And then when the ambulance team arrives, you have to hand over the patient to the ambulance team, and they should continue basic life support until the patient reaches the hospital. You should not stop resuscitation for any reason, because even brief period of stopping resuscitation can cause serious hypoxemia, especially to the brain, right? So it should be continuous, good quality, basic life support if you want to save the patient with an intact brain, right? So that is the algorithm, simple algorithm of the basic life support. So in summary, the BLS is a skill that you learn by everybody, irrespective of their profession, but essential for doctors. Should not be a doctor if you don't know BLS. And do not hesitate to provide BLS whenever you encounter a cardiac arrest patient, because as a doctor, you are obliged to provide basic life support. If you just look other way and go around without helping a patient who is in cardiac arrest, you can be even charged by the medical council for negligence, right? Because you are supposed to be responsible doctor. You can't look away and go away without attending to a seriously ill patient, right? And then the important thing is these guidelines change, right? These guidelines, drug doses changes from time to time. So need to get updated about the theoretical knowledge about these algorithms. And then you have to keep your skills alive. That means you have to practice your skills continuously, because you get de-skilled with time. So chest compression methods, the mouth-to-mouth breathing, airway maneuvers, you have to learn and practice repeatedly. That's why in other countries, you have to take a certificate of basic life support every 2 years. You have to go for a course and provide the certificate. Otherwise, they will stop your payments, right? So it's you have to get to there are skills lab around nowadays. Good dummies are available in most of the skills lab. So you can practice them. So make sure that you continuously practice your skills and keep them alive. And uninterrupted basic life support, I told earlier, most important thing, most important take-home message is uninterrupted, good quality basic life support should be provided to a patient who is in cardiac arrest until advanced life support is started in the hospital. So advanced life support is where you connect the patient to a monitor, start oxygen, give in drugs, and check the rhythm of the cardiac arrest and manage the patient according to the arrest rhythm. So that is advanced life support, right? I think that brings to the end of this lecture. So I would like to answer any questions you have about this basic life support or any area that were not clear to you. Any questions? Are you all muted or?
No, so they can unmute and ask even chat box
Okay.
also.
Okay, right. Because chat box, there are got other messages going on. That's why. So if any questions, you can unmute and ask. So possibly this is not the first time you maybe heard this lecture before if it during a medical school as well. So in the absence of any questions, we'll wind up this session. So hope you will go and practice these skills, right? And then
yes, sir.
somebody asked a question in what?
Yeah, there are 9 simulation centers in the country, so they can go and join those simulation centers and get the training on those simulation centers also. So thank you very much, sir, on that detailed lecture on basic life support. That's Professor Priyanth Pereira, Professor in Pediatrics in Faculty of Medicine in Ragama. Thank you, sir.
Okay, welcome.
Thank you, sir. So next up is airway and ventilation by Dr. Amali Dalpada, consultant pediatrician at KDU.
Thank you very much. Just see whether you can see my...
Your mic is not loud enough.
Yeah, is it better now?
No, still looks distant.
Okay, is it clearer now? Better?
No, it's clear. I mean, the volume is not sufficient.
Maybe
It
because
seems
I'm
like you're
using
far
a
away.
couple of masks. Just give me a second.
Sure thing.
I'll try to remove one or two. Right. Okay. Is it better now?
Yes, yes.
Yeah.
It's okay.
Okay. Right. Fine. So we are going to do the airway and ventilation. I hope you can see my screen. And how long do I have for this lecture? How long do I have for this lecture? Hello? Can you hear me? Hello? Can you hear me?
Yes, madam, can hear.
Yeah, okay, okay, thanks. Is it Rajita? Is it Rajita? Rajita, are you there? Hello?
Oh, madam.
Rajita, how long do I have for the lecture? When should I
Yes.
finish?
Yes, madam.
When
Oh,
should I
40
finish
minutes.
the lecture? 40 minutes.
40 minutes, yeah, madam.
40. Okay, thanks, Rajita.
මේ
So
කවුද
it's-
ළමයෙක් නේද?
right, okay. So please mute your microphones unless you're asking questions, Nilmini. So we are going to talk about airway management in the APLS. I'm Dr. Amari Dalkatadu, Senior Lecturer at KDU, and I'm a pediatrician at UHKDU. So airway management is one of the vital things in pediatric emergency support, because airway is the first step in your acute pediatrics, right? So we are going to talk about airway and breathing. We do have a few objectives to talk on. So we are going to talk about the structured approach in airway and breathing. So it's always, we have to oxygenate the child. So airway is the key and the first step. And
Madam, your slides are not moving as it.
Okay. Can't you see the airway?
We can see.
Uh-huh.
No.
You
Stuck.
can't see. Okay, I'll
Yeah.
stop share and I'll try to share the slideshow. Can you see the objectives now?
Now it's better, yeah.
Yeah, okay, thank you. So we are going to understand the structured approach to airway and breathing and introduce you to a few equipments which is being used. And also, we are going to discuss a little about intubation as well, right? So, skills. So airway management, there are a few basic maneuvers to open up the airway. So those things everybody can do without any equipment, and everybody should know to save lives of children. And adjuncts. Adjuncts are supportive equipment which will help you to maintain the airway before going for a definitive airway, which is the tube, intubation. And we are going to talk about intubation as well, a little bit, introduction, because now you are going to go to be posted on post-intern appointments. Hopefully you will be work as a middle grade doctor, where you might be called to have a proper definitive airway inserted. And options for failed intubations also we are going to discuss a little. Some of you might be working in pediatric wards and emergency treatment units where you might need this support. And of course, we have a sequential response and some simple techniques, often effective and life-saving. And remember, the gastric tube is often also requiring this. Second, hello. Oh. No, nutrition. Okay, thank you. Right, so next we are going to talk about anatomical differences. What are the differences in a child versus an older person? So the children have a large occiput, which actually causes neck flexion, hence the obstruction. So when you have a large occiput, when you're keeping on a board, it flexes the neck, and that actually flexes the airway, which causes obstruction. And if the child is less than 2 years, mostly the infants we are talking about, you might need a shoulder roll, a support behind the shoulders to lift up the shoulders so that this flexion does not occur. And they have larger tongues which can fall back easily. And the larynx is high and fairly anterior. So when it's anterior, so you're putting the your laryngoscope this way, you might not be able to visualize it very clearly. And the epiglottis is also very floppy, might be very difficult to maneuver it using your laryngoscope. So this is the differences between an infant and an older child. So first thing in the airway is the positioning of the airway. So neutral position, we talk about neutral position, which is keeping the child head parallel to the ceiling and the floor. And in an older child, it's sniffing position, slightly moving the head slightly up, like sniffing the morning air. That's what you call the sniffing position. So this sniffing position is used for children who are older than 1 year. Neutral position is children less than 1 year. So the basic maneuvers of opening the airway, we do the chin lift and the head tilt. So this is the head. When you are tilting the head, the child is in a horizontal plane. You tilt the head slightly and lift the chin using 2 fingers. So you use 2 fingers. You don't push it upwards. So you lift it forwards in this manner. But if the patient is in a supine position, you are rather lifting upwards using 2 fingers, touching only the bony points. You can observe it very nicely done in the picture. And the jaw thrust. Now with the COVID, we really encourage you to do the double-handed jaw thrust rather than doing the single-handed jaw thrust. Mind you, the head tilt is not done when there's a suspicion of cervical neck injury, and also in children who are probably younger, the newborns, we don't do the head tilt. Okay, so the adjuncts. Now, first thing is the airway positioning. Second step is the airway opening maneuvers. We spoke about head tilt, chin lift, and jaw thrust. Next, we are talking about the adjuncts. Adjuncts are supportive equipment or supportive artificial airways, which is going to keep the airway open in a child who is having a risk for closure of the airway. So this is the oropharyngeal airway or the girdle airway, as you may all know. So the measurement of the girdle airway is from the middle incisors or the mid lower lip to the angle of the mandible. Now you can't see my angle of the mandible because I'm wearing a mask, obviously. So it's here to here. So you measure along the curvature like this and take the appropriate size airway. So you put it along the curvature of the mouth, or you can even turn it. Now they say you can turn it, but as long as you remember, you can put along the curvature, that's enough, right? So size, this is how you measure, and that's how you insert. You can use a tongue depressor or a laryngoscope to depress the tongue to help you in inserting the oropharyngeal airway. That's the girdle airway. So nasopharyngeal airway is another airway, especially children with cerebral palsy or reduced level of consciousness. When they find it difficult to maintain the airway, we use the nasopharyngeal airway. We can't use the girdle airway for a nasopharyngeal airway. Sometimes there is actually a proper nasopharyngeal airway, but the moment most of the centers do not have it, then we probably use the ET tube cut short, and then we use it as a nasopharyngeal airway. So here again, the length is, this is the lateral edge. I mean, you can't see my nostril. Lateral edge of the nostril to the tragus. You know where the tragus is, tragus of the ear. So here to here, lateral edge of the nostril to the tragus of the ear, that's the length. And diameter is the little finger or the nostril, right? So it should be slightly smaller than the nostril, and you have to lubricate it and put it inside. And if it's a ET tube, you have to cut it to, ensure the size is appropriate, and you have to insert the top part because otherwise it might dislodge, right? So it has to be properly connected. You have to lubricate properly, so posteriorly directed rather than upwards. So you have to rotate gently while you're inserting it. So again, if the patient is unconscious and there's a noisy breathing, usually if the patient is unconscious with a reduced level of consciousness, we think, okay, there might be concerns of having airway issues. Usually they say as a limit, if the GCS is less than 8, you have a risk of having airway issues. So therefore, those patients, you might have to be mindful. You might have to think of proper having a definitive airway. You might have to clear the airway or use the adjuncts. Always, now when you're, there may be patients who are having a seizure, who are having a lot of secretions, you might have to clear the airway. So when you're clearing the airway, you should make sure you put the laryngoscope and then clear the secretions. Most of us, or sometimes the other staff, allied staff, are used to doing the suctioning. Now this is the mouth of the child. They just put the suction catheter and then just clean around and they just pull it out. So that is just blind suctioning, which is really harmful sometimes. You should never do any blind suctioning. All the suctioning should be done under direct vision. So it's very important that you all remember this. So whenever you are suctioning, you should do it under direct vision. So this is why on top picture, you can see the Lanka sucker, which is the preferable method where you remove the secretions, where you have a small hole. So you put inside the sucker handle. While withdrawing, you close the hole and you withdraw it slowly. So that's how you do the suction. And the suction pressures also can be titrated. I mean, a better suction apparatus. Most of the places that you can increase the suction pressure, but there's a appropriate size also. And you have smaller tubes for smaller children as well. Okay. So that's about suctioning and clearing the airway. And also we talk about breathing difficulty. So now we talk about COVID and breathing difficulty. So a lot of people are complaining of breathing difficulty. Children are complaining of breathing difficulty. So you might be working in a COVID ward when you go as your post-intern. So there are simple measures in a child or an adult with a breathing difficulty. So this is first one is the nasal prongs oxygen. I mean, you can go up to 4 liters of nasal prongs oxygen, which will provide appropriate amount of oxygen. And this is a mask, just a clearly fitting mask where you give oxygen. You can go up to even 10 to 15 liters. This is a refilling bag. This increases the oxygen percentage which is being delivered to the patient. So there are ways that you can monitor the oxygen concentration. Like now you have the small finger saturation monitors, and you have more complicated, more high-tech monitors where you can get the saturation, you can get the respiration, you can get the heart rate and the blood pressure. But it's really important that you maintain your saturation above 94. If a COVID patient is having a respiratory difficulty less than respiratory difficulty, then it actually falls into the moderate to severe category where you need to do some intervention. So a little oxygen saves lives. So again, oxygen therapy for COVID patients, they talk about putting the oxygen on top of the mask or under the mask, where the rest of the staff or the people around him, bystanders and the other patients are not contaminated. So you put on a surgical mask on top, or on top of the surgical mask, you can put the oxygen mask. I think this second one is more appropriate, where you put the oxygen mask and top of that you cover with the proper mask. Try to minimize the amount of leak outside into the environment, right? So you have to make sure that you have this. Okay, so you will talk about newborns, little neonates in the neonatal units, and some of you might be working in a CBUMO as your post-intern appointment. So the first one I think you see is the NeoPuff. NeoPuff is a small machine where again you can provide the positive pressure ventilation. It doesn't have a bag like the usual bag and mask, or you call the embu ventilation, where you have a small hole. Whenever you want to give a positive pressure, you occlude the hole and remove the finger. So there's a small hole. I don't know, you can appreciate. There's a nurse next to the doctor, and she's occluding and removing. There's a mask which is on top of the baby, and connected to the mask is a T-piece, and on the top of the T-piece there's a hole which you occlude and remove. And there is a pressure gauge, pressure monitor, which you see like probably like a clock, where the PIP, or the maximum pressure delivered, is you can see up to 20 or even higher than that you can go. So there's a way that you can titrate it. And you can even deliver a PEEP, or a positive end expiratory pressure. You can maintain a pressure to avoid the atelectasis. So that is better. Most of the resuscitators do have a neopuff, but some of the older resuscitators where you might be working on may not have a neopuff, which you might be working in the bag and mask as you used to be. So the second one is a CPAP. CPAP is again the continuous positive airway pressure. Again, that maintains a end of expiration pressure in the airway. So that actually helps the patients to avoid any atelectasis. Now, this is really used in newborns where they are having a respiratory distress and they're having a risk of atelectasis, especially the newborns with prematurity, and they probably need to keep the airway open, and they're spontaneously breathing. You don't need to provide any positive airway pressure. Again, BiPAP is another form of non-invasive ventilation where you don't really go into the definitive airway like putting an ET tube, but there you provide a positive pressure on top of the baseline pressure. So you keep a baseline pressure to maintain the airways open, and on top of that you give another pressure which actually gives a positive pressure which helps the patient to oxygenate himself. Where the patient's breathing is not very effective, we need to have a BiPAP, right? So high flow nasal oxygen is the one which is very popular now with the COVID, and it has saved a lot of lives. And I think before the COVID, it was doing wonders with babies who were doing who were having bronchiolitis. I think especially during the winter months, during my foreign training, I had a lot of experience where they used a lot of high flow nasal oxygen therapy, where a lot of lives are saved without going for ventilation and invasive procedures, where you provide oxygen flow. Now this is the nostril, and 50% of it's occluded with using the tube which you insert it. Now, not like in CPAP where there's in CPAP you have either a mask or a tube, like a nasal prong. It's a prong or a tube which is really occluding and really with a tight closure. But in high flow nasal oxygen, where you don't have a tight occlusion. Hello, who's this? Hello, yes. Any questions? Lakshmi, you want to talk to me or anything? Hello. Yes. Okay. All right. So if you are not if you want to have any questions at the end of the lecture, we can always talk about it. So we were talking about high flow nasal oxygen. So in high flow nasal oxygen, we occlude half of the nostril, and the oxygen goes with a higher pressure, right? This is just a flow of oxygen into the airway, which again keeps the lung from atelectasis. So that provides a sort of end expiratory pressure that you can set up end expiratory pressure, and that provides you with a high flow, which provides the oxygenation. This does not provide a positive pressure, like when the patient is not breathing, you cannot go on to high flow nasal oxygen. So the ways and means, most of these are non-invasive type of ventilation techniques I spoke about. We spoke about neopuff in neonatal resuscitation, where you can provide the end expiratory pressure, and you can provide breaths as well, positive pressure, and a CPAP, which only provides the end expiratory pressure, where the patient is spontaneously breathing on its own. A BiPAP provides a positive pressure where you give a support for the breathing as well. And in the high flow, patient is breathing on its own, where you provide the high flow oxygen, a flow of oxygen, which keeps the end expiratory pressure while oxygenating the patient. But it does not provide a positive pressure to ventilate the patient, where the patient is breathing on its own, right? I hope things are a little clearer. So these are the bags. I think you are more comfortable, you are more aware of these bags. Especially one thing that you have to remember, the infants, all the infants should have a round mask. Whenever you go and work in your peripheral stations, make sure you talk to your seniors, talk to the administrative staff, and make sure you get a circular masks for infants and newborns. So the circular mask is the round one. The other mask, the triangular shaped one, is the physiological mask. The physiological mask is used for older kids, right? The circular mask is used for newborns and infants. So if you don't have a circular mask, you should try to talk to your professional director or regional director and get one for your station, because otherwise you won't be having a proper seal in a newborn. So there are different sizes of bags, 250, 500 and 1 liter. So basically for children up to 500 you will be using. The second type is a T-piece. Now T-piece is like a T, where one end goes to the mask, the other end goes to the oxygen connector, and there is another end with a bag, free end. Usually these are used by anesthetists. And the bag here has an open end. So when the oxygen flow is coming from the green tube to the mask, it goes to the mask and it goes the other way to the bag. By squeezing the bag with your 2 fingers, you can again provide a PEEP, that is the end expiratory pressure, that is to open up the airway. Usually when you're anesthetizing, you use this type of ventilation, and by squeezing the bag intermittently, you can provide some sort of ventilation, right? So these are the masks. So when you're selecting the mask for the child, it should cover the mouth and the nose. Both should not go above the eyes or below the chin. So the correct size mask should be selected. So positioning of the mask, you again, I think you're being taught in medical schools, the C and the E technique. This is the E, this is the C, right? The C is held by the connector of the bag and the mask. The position where the bag and the mask is connected, your C. And the E, either the 4th or the 3rd finger is used to give your jaw thrust. So C and E technique, that's very important. I think it's very difficult to teach the C and E on a Zoom session, but I hope when you go for your simulation centers, your practical training, that you will learn it properly, right? Okay, so bag and mask ventilation. So you should provide enough pressure to get a chest rise. So that is, you are giving a positive pressure and you are getting a chest rise, right? So you have to position, and I think we spoke about the position. So you have to position the airway, and you have to open the airway using the head tilt, chin lift and the jaw thrust. And then you go for the adjuncts, and then you start your artificial ventilation. Here you have to adjust your positioning, the airway opening maneuvers, until you get the proper chest rise. Okay, so we talk about rapid sequence intubation as well. So rapid sequence intubation is, now we spoke about the patient, now we spoke about BLS. I think Prof. Priyantha spoke to you on BLS. So in APLS, what we do is we teach you the BLS, and there's a station where you checked on BLS, and there's a station on APLS where you learn on airway as well. And we have some videos where we have produced where you can see and understand the sequence of airway, right? So once you have done the artificial ventilation, still you cannot get a chest rise, then you have to think about intubating or getting a definitive airway. So intubation is a rapid sequence intubation, because this is not a patient who is undergoing surgery, who is being fasting. So therefore, you have to pre-oxygenate the child. So make sure that you pre-oxygenate up to 3 minutes in preferably 100% oxygen. Now say you are ventilating a child or intubating a child who is having a cardiac problem, and the maximum you can go is 80, you can't go to 100. But according to what you can get, the best you can get, preferably 100 up to 3 minutes. And then you have to give a cricoid pressure. Cricoid is the dip here. So you give a pressure so that your larynx will be more visible. So I usually do it with my own hands, but then you can get one of your assistants to give the cricoid pressure. But make sure when you are, sometimes they may obstruct the vision even. So when you are giving the cricoid pressure, you go inside the laryngoscope and you ask your assistant to keep the hand where you prefer them to give the cricoid pressure on, right? So you keep hand on top of the cricoid, then move the larynx, and then they can visualize it. So that is to avoid any aspiration. And then you give predetermined boluses of drugs. I mean, different units use different drugs. You can use thiopentone sodium. You can use different drugs according to the situation as well, right? Whether it's blood pressure lowering and all that. And usually you use a short-acting muscle relaxant like succinylcholine, and sometimes you give a pain relief as well like morphine. So you have to intubate immediately. So you have to have few people. You have to have a team leader, may or may not be the person who is intubating, and there should be a nurse or a doctor who is getting IV access and giving the drugs, and they should prepare the drugs and get the IV access before you start going in. And there should be a person who's getting ready with the equipment like the tube, and in a difficult airway with the bougie and everything, and a running nurse who's going around and getting things done. And also, of course, you should document the time. So first you pre-oxygenate, you give the cricoid pressure, and then you make sure that all the drugs are given by the nurse. After your muscle relaxant is given, you get a bit of fasciculation, and then you observe, then you try to go in. So when you are intubating, you go inside, you usually hold your laryngoscope using your left hand. Because I'm right-handed, I use the right hand to intubate or hold the tube. So you insert it, and then if you cannot insert it, maximum you take is 30 seconds. Or if the heart rate is dropping, you have to come out, and then you have to try again. You have to pre-oxygenate again, and you have to go in. So 2 attempts per person only. I think the most senior person should go in next if the junior person cannot intubate after 2 attempts, right? So avoid ventilation if possible, but of course, having said that, if somebody is going into a respiratory arrest, you should not say we should avoid ventilation, therefore we should not intubate this child. So you should not be be judgmental like that. Everything should be taken in a light where you make decisions in a critical manner. And once you have intubated, the tube position is confirmed, the cricoid pressure is released, so that the aspiration risk is less. Okay. So you pre-oxygenate and you give cricoid pressure, you give predetermined boluses of drugs, and avoid ventilation if possible. Of course, if necessary, that should be thought of before this, and intubate immediately, and the release of the pressure once you have inserted the tube. Okay, this is the pre-oxygenation in a newborn. I think you can nicely observe the C and E technique, but however, I see that some of the soft tissues under the area then is being little pressed, but I hope they are not pressing too much to obstruct the airway as such, right? Okay, so again, the drugs nurse, there might be a sedative, and there might be induction agent or a muscle relaxant. So sedative may be some sort of morphine. It depends on again your unit policies. Induction agent, most of the time you use TPS, some people use propofol. Muscle relaxants most of the time, and I mean sometimes if you're going to ventilate for a longer period, you might give something slightly moderately acting one, but most of the time it's succinylcholine. Resuscitation drugs should be ready, like atropine and adrenaline. So fluid should be ready. You should give given fluid boluses if necessary. So you are not giving all these sedatives, muscle relaxants, and induction agents in a patient who is in hypovolemic shock, because these also tend to drop the blood pressure and patient might go into an arrest. So you're not going to intubate in a child who is not cardiovascularly stable. You have to stabilize first, give the bolus and start on your inotropes or whatever, and then only you have to give these drugs and think of intubation. So drugs of normotensive, drugs for hypotensive patients, and drugs for bronchoconstriction patients you should have in mind, right? So drugs like ketamine, you might not be using for broncho patients who are having bronchial asthma, and so on and so forth. And some patients cannot be used in diabetes as well. So here you see the monitors where the heart rate is seen in green, and the blood pressure is seen in red, and the saturation is seen in white with the respiratory. I think that it's connected to the ventilator, where you see nice boxes, where usually when you're connected to a ventilator only you see nice ETCO2 boxes. and the laryngoscopes. And we didn't talk about the laryngoscopes prior to the ventilation. Usually there's a straight blade and a curved blade. Straight blade is preferable in infants. Straight blade is preferable in infants, and the curved blade is older children. And in the upper picture where the two tubes are there, this is a cuff tube and this is the uncuffed tube of a newborn, right? So you have inserted a stellate, and stellate should be curved in such a way according to the natural curvature of the child. Otherwise, you're going to find it difficult. If you have a straight tube, you try to intubate in a curved surface, right? So we use micro cuff tubes, not the fully cuff tubes. We use micro cuff tubes in pediatric patients, but not in newborns yet, right? These are sucker handles where you see, this is a Lanka sucker, this is a normal sucker handle, and you have some sucker tubes as well. These are different sizes and sizes of tubes, both cuff tubes and uncuffed tubes, and you have some sucker machines here. So ET tube size determination is, once they're over 1 year of age, we have a formula. So age divided by 4 plus 4 for an uncuffed tube. And if it's a cuffed tube, it's plus 3.5. Age divided by 4 plus 3.5. In a term infants, usually you can use up to 3.5, but depends on the size of the baby. You might even use a size 3. But in a preterm baby, you might go up to size 2 tubes, right? So, and you should always have one size below and one size over the size that you have calculated. And the ET length should be age divided 2 plus 12 in the oral tube. Usually we intubate orally. Some people do intubate nasally also, which requires a little bit of training. Now you see nicely the vocal cords here, and the epiglottis is seen on top. These are the nice white vocal cords, and they usually move with respiration in and out, in and out. When the vocal cords are closed, you should not try to push in the ET tube forcefully, right? Okay. Now here they show you how to insert the laryngoscope. They use the left hand. Now, if you are using a curved laryngoscope, usually you push the tongue to the, this is the right hand side of the patient. My right hand is on the right hand side of the patient. You push towards the left hand side using the laryngoscope. But if you are using a straight blade, you go below the tongue and try to lift up both up to the level of epiglottis. If you are using a curved blade, you go to the vallecular fossa here. Vallecular fossa, rather going above the epiglottis and try to lift it up, right? In a straight blade, you go right down and you lift up the epiglottis as well. Okay, so that is the difference. These are some pictures. So again, this requires training. So you have to at least perform in a mannequin once or twice and on anesthetized patients under supervision. And then afterwards, you need to do it on real patients, right? So intubation, the basics of intubation is SOAP me, right? SOAP me is SOAP, S for suction, you need the suction. O for oxygenation. Jungs, you need probably some jungs like oropharyngeal airways and even laryngeal mask airways, where if you are unable to intubate, you might need to use it. Positioning of the patient, pharmacology, monitoring of the patient, and you need an escape plan. If you fail, what should you do? An endotracheal tube, different ranges and sizes. Okay, so intubation after insertion, you have to make sure that oxygen is being connected before and after. Failed intubation as well. Confirm the position clinically. Usually there are 3 points, both sides of axillae and the epigastrium you should auscultate. And the heart rate will rise and the saturation will rise. Chest expansion will be seen. And check for any air leaks on either side of the neck and confirm the position using CO2 monitoring devices. You have the end-tidal carbon dioxide monitoring devices, some of the places, but you may not find it all the time. The usual monitors in the wards do not have end-tidal. It's only in the theaters you have the end-tidal monitoring devices. And check for the leak, especially in the uncuffed tubes. And the cuff, probably make sure the cuff is not over inflated and secure the tube properly. So usually you have a plaster with 3 strips. If this is the tube, so one strip goes around the tube and one on either side of the lip. And some people do put on either side, which is crossing and then securing it a little bit more. Usually in our context, we use the pink plasters, which is a little damaging to the preterm babies, which is a little difficult, but we do not have the proper tube connectors as in other countries where you connect the tube to a tube connector. Right, so nasal intubation, again, it requires a lot of training. Again, you use the laryngoscope, but you insert through the nose rather than the mouth. That's the only difference. Failed intubation. So you fail intubation, you try twice and your consultant or your SR or your senior registrar or your registrar tries twice and you cannot. Then what should you do? You should oxygenate, pre-oxygenate, right? So get help, call for help, anesthetists, ENT surgeons, so on and so forth. Consider other jumps like laryngeal mask airway, which is very easy. There's one called iGel, which is fairly good and which is easier to insert. And consider an introducer or a bougie, or of course, if you have a video laryngoscope or a fiber optic scope, if you have one. If you don't, even a bougie would do. Some people even think of start giving these orogastric tubes and then make sure that, the orogastric will go into the esophagus and then that can actually point to where the trachea is. And of course, it failed. If you cannot ventilate, if you cannot bag the patient and oxygenate, if you cannot intubate, both are there, then you have to think of a surgical airway, which is a needle cricothyrotomy and a cricothyroid puncture later on. Okay, so this looks a little complicated. However, it's not so complicated. So no anticipated intubation difficulty. You do the rapid sequence, direct laryngoscopy. If you succeed, of course, you confirm the tube position and then you keep. If you fail in the initial laryngoscopy, you try to manually ventilate and reposition the patient and try another attempt, the second attempt, and failing again, while maintaining the airway, you can try to wake up the patient and advance airway techniques like what we discussed before. Or you can try to insert a laryngeal mask if you cannot manually ventilate using a bag and mask. Still, you cannot use a laryngeal mask airway. You can use a surgical airway. So first you try your direct laryngoscopy and intubate, failing which manually ventilate, failing which go to the laryngeal mask airway, failing which you go to the surgical airway. So if you succeed at either point, then you secure the airway and try to continue the ventilation. Right? Okay. So the vortex, again, you have the face mask, you have the supraglottic airway and the endotracheal tube. And all those failing, you go to the emergency surgical airway. So that's the final step. But it has to be tried by the most experienced clinician present. So if you have the consultant who had not tried the intubation, they should try it before going for a surgical airway. Right, so this is the laryngeal mask airway. Again, laryngeal mask airway, you have the laryngeal mask. You should not be totally deflating it. There's a place where you can insert a syringe and draw the air out of the tube, the balloon-like part of it. And you should deflate it midway between full inflation and full deflation. They say the consistency like a marshmallow. And you hold your two fingers while deflating it and you feel the consistency. And then you try to insert it using your fingers. Some people do use the laryngoscope and insert it like this. Or some people use just the two fingers and introduce a cord along the airway. So that's another method of inserting it. This is how you insert it, the laryngeal mask airway. That saves a lot of time and lives for all the people. This is how you do it. This is the iGel. It's one of the better ones you do have. And in the laryngoscopes, the newer ones, the high-tech ones, you have a place where you can insert a tube through the laryngeal mask airway. It's called the fast track. Right. So these are cannot intubate, cannot ventilate situations. You do a surgical airway. Of course, you need the surgeons to have a definitive surgical airway, but you can do an emergency technique using a needle cricothyrotomy. Okay. So in summary, bag and mask ventilation and intubation skills require time to practice. You should never hesitate to call for help. But that doesn't mean you should be always calling somebody's help. You should get used to it. You should practice it. And you have to have a fair plan for failed intubation. You have to ventilate as necessary. You should not be afraid to assist respiration. And you should always monitor the effectiveness of your procedure or the support. Hello? Oh. Nutrition academic. Thank you. Right. Okay, that's it. I think if you have any questions, you can put it on the chat box. Any questions that you have, immediate questions? Any questions? So basically the airway is about the positioning, airway opening techniques, and then you go to the airway clearance using a suction and airway adjuncts like oropharyngeal airway. So first you position, open the airway, clear the airway, then put on airway adjuncts, and then you think about giving a positive pressure ventilation. We spoke a little bit about the non-invasive techniques as well. I hope you learned something through this online session, and I think you were told that there are 9 simulation centers where you can go and practice these, what you learn through Zoom. Is there a mortality benefit in prone ventilation in COVID patients? Yes, because now they are talking about the invasive ventilation. I was not talking about invasive ventilation. There is, because always the patients who are found, even newborns, even pediatric patients and even adults, because most of the 3 lobes of the lung are exposed in the posterior aspect, and then they find it easy to ventilate in the prone position. There is a benefit, definitely, but sometimes in centers where the staff is not very conversant with keeping the patients prone, it's the positioning actually, especially newborns. The challenge is sometimes if your nurses and the staff are not very comfortable in keeping the patient prone, then that's a little difficult. But most of the newborns who are difficult to be ventilated in a supine position does respond in the prone position. Any other questions that you have? Anything else? In the absence of questions, I'll wind off. I hope that brings to the end of your lectures, I suppose. Hello?
Thank you, Amalia. I'm doing the last one, transport.
Sorry, sir. I think transport is the last lecture.
Okay, right. So good afternoon, everybody. So this is the last lecture. It's about 20 minutes lecture, very short lecture on stabilization and transport of basically COVID patients. Because this is important because we have had few deaths during the transfer of COVID patients during the first pandemic and as well as the second pandemic. So we don't want this to continue. I think we need to be very careful in transporting these patients in order to make sure that they reach the hospital quite safely. 3 things, objectives: stabilization and preparation before transport, problems during the transport, and how to hand over. So we know that the COVID is droplet infections. That's why we need the meter distance of 2 meters, 1 to 2 meters, in order to prevent us getting infected. And other ways are very rare, like contaminated surfaces and the droplet nuclei. So to prevent this, we need to wear a N95 mask, face shield, and surgical gowns, and the gloves. So these are what is called personal protective equipments, and these are mandatory for the healthcare workers to wear in order to prevent us getting infected. So in fact, in a team, in patient's care facility, the most important people are the healthcare people, because they shouldn't get infected from patients, and also they need to go home at the end of the shift. Therefore, they need to look after themselves. So it's for healthcare persons are very important in healthcare facilities. Now, if you sort of wash the hands thoroughly and put on gloves, then it is clean hands. But if you sort of put gloves without washing hands, then it causes germs transmission. So this also indicates that the transmission is lower when you maintain a distance of more than 1 meter and surgical face mask, but N95 mask is better than surgical face mask. And the eye protection, by the way, face shield is also helps to reduce the infection. This is the oxygen cylinders. You should have some idea about how many cylinders you should take for this transfer. And you should know the capacity of each cylinders. The medium cylinders were 1,200 liters, jumbo cylinders close to 7,000 liters. So if you use 5 liters from a medium cylinder, it lasts only 4 hours. But if you use 15 liters per minute from a medium cylinder, it lasts only 1.5 hours. And jumbo cylinder, 5 liters per minute, lasts 22 hours. And if you use 15 liters per minute for a patient, it lasts about 7.5 hours. So therefore, it's important that you should have an idea how many cylinders you should take to reach the patient to the receiving hospital. Then you should know what the signs of symptoms of COVID. I think this was dealt in the morning, like rhinorrhea and body pains, tiredness, distaste, severe headache, and also they can have vomiting and a bit of loose tummy. Then how do you find out whether you need hospitalization? I think you can probably call this number 247. You probably would have worked in this 247. You can actually join as 247 team as a volunteer. And then the patients will keep calling you, and you need to decide whether to sort of advise them to be at home or whether the patient needs transfer to a hospital. So how do you decide whether the patient needs to go to hospital? If he's having short of breath and difficulty in breathing and continuous cough, temperature more than 101 for 3 days, chest pain or chest discomfort, and headache or the dull headache, and some can be severe headache, giddiness, all these things needs hospital admissions. Then if you have pulse oximeter, if saturation less than 95%, they need hospital admission. And this is in the peri-arrest situation like cyanosis. So now, before you transfer the patient, it's important to check the patient's vitals. So the most important vitals in this patient out of the A, B, C, D, E, F is the pulse oximeter reading. So you check the pulse oximeter reading and make sure you get the patient to the ambulance. Either you can get them to walk, or you need to put the shift the patient from patient's bed to the ambulance stretcher and then transfer the patient. So when the patient is loaded, again, you need to check the saturation for the second time. So the first time you check the saturation before you lift from the patient's bed, and second occasion you check the saturation after a couple of minutes, 2 minutes after loading the patient into the ambulance. And then make sure the patients, you adjust the lower saturation alarm limit to 95. In the patient's monitor, adjust the lower saturation alarm limits to 95. And also the other important thing is turn the patient's monitor towards the accompanying doctor. So if the doctor is sitting on the back, you need to look at the monitor. If the doctor is sitting in the front, you have to turn the monitor to that side so that you can keep watching during the transfer. And the other important point is before you start the ambulance, make sure that the windows are open on both sides. Why windows are open? When the ambulance is moving, there's cross ventilation. So the COVID density inside the ambulance is going to be less, and your chances of getting infected is much less. So these simple things you need to do before you start the ambulance, start the journey. Now, which said you need to check saturation twice before you lift the patient from the patient's bed and after loading the patient into the ambulance. So if there's no symptoms and saturation is normal on both occasions, you can be happy that the lungs are not infected. No symptoms, saturation is normal, but when the patient walked into the ambulance, the low saturation, that means there's exertional, there's a desaturation on exertion. So which means lungs may be infected to a certain extent. No symptoms, but low saturation, lungs are definitely infected. And symptoms like shortness of breath and low saturation, lungs are definitely infected. So in those cases, you need to provide oxygen to make the saturation above 96%. So in fact, the last two is called silent hypoxemia. In fact, third one is called silent hypoxemia. So what you should do is to start on face mask oxygen. So face mask oxygen, the minimum is 5 liters and maximum is 10 liters. So if you can't maintain 10 liters with a simple face mask and can't keep the saturation about 95%, then you have to change into a non-rebreathing mask where the minimum flow is 10 liters and the maximum flow is 15 liters. And also make sure that you put a surgical mask on top of the face oxygen mask in order to avoid the aerosol generation to the environment. So this was all mentioned in the morning, Dr. Nalin Kitulata's lectures and Deshan Sadhiti's lectures. So this, and also this is also mentioned in the morning. Before you put the start on non-rebreathing mask, make sure that the bag is inflated with oxygen and then put it on oxygen. Otherwise, it doesn't work. Patient get hypoxemic. Then the ambulance is moving. You need to concentrate on the patient's monitor and concentrate on saturation, concentrate on pulse rate, concentrate on blood pressure. So make sure that these are normal and stable. And also look at the patient's behavior, respiratory rate, and the level of consciousness. Sometimes it's a bit difficult because the patient fall asleep. So in the event that the patient saturation falls less than 95% during the ambulance, please stop the ambulance. Don't go on because don't continue. The patient will get arrested on the way. Stop the ambulance and try to rectify so that if the oxygenation is, if oxygen mask is shifted away, you need to refix the oxygen mask. Make sure the tube are well placed and make sure the oxygen cylinder is over and then replace a new cylinder, So all these things are important in order to optimize the oxygen. Suppose non-breathing, simple face mask, 10 liters doesn't work, then you discard and then start on a non-breathing mask and go up to 10 to 15 liters per minute and make sure oxygenation is optimized. So these things you need to do. And then once the patient is stabilized oxygen again, then you can restart the journey. So don't continue the journey when the patient is desaturating. And your job as the doctor who is looking after the patient is to monitor the patient during the journey. So in unfortunate events, you have to give bag and mask ventilation. You need to use double-handed jaw thrust to give bag and mask ventilation, where the indications are respiratory less than 8 gasping breathing, or irregular breathing. Then inside the ambulance, when the ambulance is on the move, the monitoring are difficult, especially in the night because of the poor lighting, and sometimes vibration because the ambulance sometimes not is running on the carpet road, sometimes gravel roads, and they take bends so that there may be a lot of vibrations and cause problems. Temperature sometimes can be hypothermic because of severe cold, otherwise can be warm as well. Communication is difficult because you can't communicate with your consultants who is in the referring hospital because sometimes your signals are not there, and your consultant's phone may be busy. Sometimes you are also tired, you feel a bit vomitish inside the ambulance, and you lose concentration power to monitor the patient. So in those patients, I think it's better to get antiemetic before you board into the. What are the challenges and divisions? Shared care. So always your transfer should be supported by the consultant or the senior doctor in the referring hospital. Movement and safety. Once the patient is shifted from the patient's bed to the ambulance stretcher, you might get stuck in the staircase in the lift of the hospital because it's not functioning well. You might get stuck in the traffic, so that you need to look after the patient. And resource, obviously, there are resource limitations, so that's why you need adequate number of oxygen cylinders and other equipments that need to go in the ambulance. Then unfamiliar equipment, sometimes you might see this equipment for the first time, you don't know how to operate it, and it's a bit of problems. Therefore, you have to familiarize with it. Clinical isolation. So most of the time, you are with the patient, you have to take the decision on your own, and then you have to inform to the consultant and then try to get some clarification advice. What do you mean by physical and physiological changes? When the ambulance is speeding up, it might cause a bit of a deceleration, acceleration forces. And on the other hand, when the ambulance applies brake, that also can cause this type of forces. So these forces can actually affect the hemodynamics and the oxygen saturation of the patient. So that is what is meant by physical and physiological changes. Then when you want to communicate over the phone to either referring hospital or receiving hospital, always use SBAR, situation, background, assessment, and recommendation. And first is I is introduce you and find out who's speaking there on the other side of the phone. Situation, COVID positive patient, shortness of breath, and the name and the age. Background, positive yesterday, difficulty in breathing from today. Assessment, saturation in air was 92 with oxygen 97, and the blood pressure and the pulse rate. And recommendation, what you have done? You have probed the patient. You are basically taking the patient as instructed to this particular hospital, and you are putting him on simple face mask oxygen, and this is the saturation. So anything else that could be done, you need to ask from the doctor. Then the other factors that affect the mode of transport, we transfer by road. So the nature and severity of the illness is very important in order to decide the urgency of the transfer. Now we clearly said a patient who needs non-TBD mask oxygen, more 15 liters per minute. If you can't maintain saturation above 95, that patient is very ill, acutely ill. If you transfer that type of patient, the patient is going to get a cardiac arrest. Therefore, you have to make sure these patients need to go to not to the designated hospital, sometimes the closest hospital, so that you need to stabilize this patient and then start the transfer again. So I am going to repeat again. The most sick patients are the patients who need oxygen through the non-breathing mask with the liters of 15 liters per minute oxygenation. So those patients might get arrested on the way. So therefore, those patients need urgent transfers. And the message is, don't wait until the patient requires 15 liters per minute of oxygen through the non-breathing mask. The moment they are reaching close to 10 liters per minute, the simple face mask, you need to transfer so that your you can reach the receiving hospital. Mobilization time, you should have an idea how long it takes to reach the hospital. Geographical factors, you need to consider sometimes if you are going on the hilly road, gravel roads, and sometimes there are landslides. Weather, heavy rain, heavy showers, can't see the road, misty roads, and the thunder and lightning. So that also affects the travel. Traffic conditions, when you get to the city, make sure you don't get stuck in the traffic so that your transfer get delayed. Okay. And then when you can't reach the hospital, make sure that you reach, you have to park the ambulance either in the accident and emergency department or in the OPD admission counter. So one of those places you need to park the ambulance and then unload the patient and then take the patient to the emergency treatment unit or the COVID ward. You help to them to shift the patient from the patient's trolley to the ETU bed, and after shifting the patient, make sure you stabilize the airway, breathing, circulation, and disability with the support of the receiving hospital staff. And also, it's important that you then you hand over in detail to the doctors and nurses on duty on the patient, like A, B, C, D, E, and bit of history, and also introduce the bystander to the sister of the ward. And also then hand over what are the forms that you brought in: transfer forms, patient's note, X-rays, CT scans, and other referral letters. And then, having done that, make sure patient is stable, and then you can actually remove your PPE and put it in the correct dustbins, and at the correct dustbins, and then dispose everything. And then start washing your hands, because the hands can carry millions of COVID particles. Therefore, there are 5 steps of hand washing. This rub to palm, rub palm over the left dorsum and left palm over the right dorsum, and then palm to palm, fingers interlace, and then back of the fingers, opposite palm, and then thumb, and the back side. And so you do like this, and then you do like this, and then fingers interlace like this, and then skin creases of the palm, and then thumb, and then wash the hands. So this is called hygienic hand washing, and having done the hygienic hand washing, you can still realize, you realize that still the germs are remaining in these yellow areas. The pink areas is to a lesser extent, and basically its washed areas are light yellow areas. So therefore, make sure that you do a proper hand washing, try to minimize the germs on your hand. So as I said before, if you don't wash, it's a home for the millions of microorganisms. It can double in 30 seconds and it can spread. Then after that, you can actually use alcohol scrub to again to clean your hands. The advantages is because less time and more effective, much more effective than soap and water, and it maintains sterility for 3 hours. Applied properly, and it improves the skin. So these are the advantages of alcohol spray. And this type of transfer, from the time you pick up the patient until the patient is unloaded into the hospital, this transfer should be monitored by either receiving hospital or the referring hospital. So this is serial 1990. All these transfers are monitored by this person called ERO, Emergency Response Officer, in the control room until the patient is handed over to the hospital. And then all the documents should be documented. So they document on what is called a PCR, Patient's Record Room, Patient's Record Report. And once that is completed, the carbon copy is handed over to the hospital to go to the BHT. So make sure when you get patients from source area, that PCR or patient's record form is attached with the BHT. Otherwise, you can always ask the ambulance crew that report, they should leave it with the hospital. And the original document is sent to the head office for statistical analysis. So what are the reasons patient can deteriorate on the way? Well, if you don't check the oxygen, the amount of the cylinders that you need to carry, then if you run out of oxygen on the way, obviously patient will deteriorate. Then if you don't know how to operate equipments in the ambulance and how to change oxygen cylinders, then patient will deteriorate. If you delay the commencing the transfer, then there's a chance that the patient will get arrested. Then if you excite the patient too much before getting into the ambulance, that also can have adverse. And if the saturation alarms are not set, the patient's monitor the ambulance, that also can be an issue. And then not knowing how many cylinders that you need to take before the transfer begins. And the very ill patient who needs non-breathing mask and requiring 15 liters per minute to make saturation about 95, just 95, might get arrested on the way. So other reasons are not observing the patient's monitor, drop in saturation, increase in pulse rate, and increase in respiratory or slow respiratory rate for that age, dropping blood pressure, and not listening to the saturation alarm. So therefore, in SOURCE area, we have made a small SOP and sent to all the locations, and they are supposed to be they should abide by this SOP. Otherwise, we consider them as protocol violations. So these points are PP, they should do a PP, check oxygen before they leave, they check the saturation of the patient very correctly with the red light onto the nail, and try to avoid the fingers where the nails are where they have applied nail polish. Then to avoid exertion before getting into the ambulance, the saturation inside the ambulance while the ambulance is on move, and prop up the patient is difficult in breathing, and it just adjust the saturation lower limit to 95, and monitor the patient during such a journey, the oxygen saturation, pulse rate, and the level of consciousness on the VPU scale, and communication with the receiving hospital or referring hospital, and always communicate on the ISPA principle. So these are the guidelines that we are given to the ambulance crew, so that they should abide by these guidelines. Okay, so then how do you get COVID from COVID during the transfer? If you suck the patient inside the ambulance, and if you do CPR inside the ambulance, and if you do manual ventilation inside the ambulance, then you can get COVID. But there is no chance for COVID infections if you do nebulize the patient inside the ambulance and introduce oxygen administration. Now, after unloading the patient, when you come back to the hospital and also at home, you have to make sure you are actually in the bubble, so that you don't get infected with COVID. How do you do that? You have to stay at home and avoid going out to the crowded places, face masks even at home, and constant social distancing, washing, and then cleaning the surfaces. And also, once they are infected, then we need medical advice. I hope you understand the difference between home isolation and quarantine. Isolation is isolating somebody having COVID. Quarantine is isolating a person who is having close association with a COVID patient. So those are the two differences. So COVID is still around, but you are in the middle and we don't have COVID. That is because you are maintaining the bubble. Therefore, you need to maintain the bubble like this, even if your COVID is around you, so that you won't get infected. And that is the job of everybody, every healthcare person. So this is the final slide. You need to think, you need to be vigilant, don't lose the insight, develop constructive critique, and get the feedback from your peers, And finally, protect the patient, protect the healthcare personnel, and promote quality healthcare. And finally, we have actually made the transfer format. So with all the checklist, this is 1990 checklist, but we'll share with you when you get emails. You can actually use that to transfer patients from one hospital to another hospital. Okay, and also I think you are always welcome to join the 247 services run by Sri Lanka Medical Association. I think a lot of interns work there as a voluntary basis. You are also requested to join this service on a voluntary basis. I think this says by October 6th, from the time of the time we started this service, we have answered 247 answered 53,500 calls, and out of them, the team actually direct requested only 1,060 ambulance transfers. So it's a huge impact on the workload on SOS area, because otherwise the call get flooded, and they don't triage patient, and they send the patients ambulance to sometimes unnecessary patients, and depriving the patient who needs to come to the hospital. Therefore, it's your duty also as RHOs, when you are working, when you are off, please join the 247 service conducted by Sri Lanka Medical Association. And I think you will get the link. I will tell Professor Indika Karnathilake to send you the link, so that you can register with them, and trying to help them out, and make sure that you do a duty towards your motherland by joining and by doing a voluntary service for the national needs. Okay, thank you very much. So if you have any questions, I think you can put into the chat box. Otherwise, I think we can close the session. Okay, it's Roshan, it's over to you.
Yeah. Thank you very much, sir. That's Dr. Sheila De Silva, consultant pediatrician and national coordinator for training in College of Pediatrician and chief medical officer in Swiss area, for the detailed lecture. So that comes to conclusion of today's program. We thank College of Pediatrician for organizing and conducting these very truthful, very detailed lectures for these RHOs that will be benefited for the years to come. So thank you once again, sir. So tomorrow,
okay, Roshan, one more thing. I think we'll send you the MCQ, online MCQ to you on Friday, so you can do it on the weekend and submit it.
Right, sir. Right. So attendance link is on the chat box. So please submit the attendance. Plus, there will be internal medicine lectures tomorrow. So join by 8:15. Right. Thank you. Thank you once again, sir.
Okay. Thank you. Thank you, Roshan. Thanks.
Recording stopped.